Okay, so yesterday we have discussed up to the seizures part. We have discussed this heat stroke also, right? We have discussed the difference between a fever and the heat stroke, the causes of heat stroke. We have discussed the medication causes, okay, the pathological causes or the morbidities like the heart failure, the old age, why in the old age people and these people got a very, very high these frequent heat strokes. We have discussed why they get in the elderly, right? We've discussed about the decrease in the surface area. We have discussed the decrease in the sweat gland density. We have discussed, right? And the peripheral vasoconstriction we have discussed in the old age. Okay, and that all contributes to a heat stroke in the old age, right? And today we'll start with the headaches. Okay, so you have three type of headaches mainly. One is a cluster headache, second is the migraine, and third is the tension headache. Okay, the cluster headache, it is mainly seen in the males. Okay, and it is always unilateral, as you can see. Okay, it is unilateral, it is seen in the males. Okay, the duration of the cluster headache is basically 15 minutes to 3 hours. So basically it will be an episode of the headache, okay, which is around your eye, as you can see unilaterally, and the episode remain for like 15 minutes to 3 hours. Okay, and it can happen multiple times of a day. It can happen at the same time every day, or it can happen just before the sleeping or at the time of sleeping also. So generally the patient was sleeping peacefully and suddenly they woke up with this pain, having this kind of a pain around the eye. Okay, so it can happen at the time of sleeping. Okay, or at the same time every day. The episodes, they are remaining last for maximum 3 minutes. That means episode always gonna be less than 3 hours. Okay, and the episode is very excruciating. It is very sharp and steady kind of pain. Okay, periorbital pain, it is, as you can see, the location is around the eyes. Okay, along with the pain, patient can also have some this autonomic signs and symptoms like the lacrimation, rhinorrhea. Okay, these kind of symptoms are also present. And lacrimation and rhinorrhea are on the same side of the eye. That means from the nose. Okay, and sorry, that this rhinorrhea and the lacrimation also is from the same eye. Okay, in which the pain was happening. Okay, so pain that happens at the same time every day or at the time of sleep. Along with the pain, patients also having the autonomic symptoms like the lacrimation or the rhinorrhea. It is always going to be a male, and the episode lasts for less than 3 hours. Treatment, it will be the sumatriptans or the 100% oxygen for the acute management. Okay, to prevent the future attacks, you need to give the patient verapamil. Okay, then you have the migraine, and the migraine is most commonly seen in the females. Just like my cluster headache, the migraine is also unilateral. Okay, it also happen around the eye, but apart from that, the patient also have the involvement of the forehead, okay, the cheeks, and all the way back to your temple and the occipital lobe even. Okay, the occipital part is also involved. So a whole unilateral area of your face, you can say, will be involved in the migraine. And the episode, they have a minimal duration of 4 hours with a maximum duration of 72 hours. So they always have an episode which is more than 3 hours, you can say. Episode lasts than 3 hours, that means a cluster. Episode more than 3 hours, that means a migraine. Most common in the females, but it could be also a male case. Okay. Unlike the cluster headache, patient won't have any autonomic symptoms. Okay, right? The rhinorrhea or the lacrimation will be there. But along with the pain, the patient can also have the nausea. They can have the photophobia. Okay, so they say, so they basically generally avoid the light. So they basically, sit in a very dark room comfortably. Okay, at the time of episode, they have phonophobia also. Okay, they will shut down the room. So basically, they will sit down in a very closed room, which is very dark, to avoid both the sound as well as the light, because they have the photophobia and the phonophobia. Along with that, they also have the nausea. Sometimes before the migraine, you can also have a migraine aura. Okay, And that could be like anything. It could be a smell, abnormal smell like a burnt of tire. Okay, it could be any visual. Okay, anything. It could be a flashes, zigzag lines, anything that happens just before my episode of migraine. We will call it a aura, and that happens because of the irritation of the fifth cranial nerve. Actually, what happens in your brain, you have this cortical depression wave in the migraine patients. Okay, it all started because of a wave which is known as a cortical spreading depression wave. Okay, this wave is responsible for the aura and the activation of the trigeminal nerve. Okay, so the aura happens, and at the same time, you will have the activation of trigeminal nerve. Now, because of the trigeminal nerve activation, the trigeminal nerve causes the release of calcitonin gene-related peptide (CGRP). Okay, and the CGRP is responsible for all the pain transmissions in case of migraine. As you can see, these are all the location where the fifth nerve supplies, right? So the pain happens in the regions supplied by the fifth cranial nerve, unilateral. Okay. So the fifth nerve will be irritated, the meninges will be irritated, and the blood vessels are also irritated, and that's because of a release of vasoactive peptides like the substance P, CGRP. Okay. The treatment, it includes the, and for the acute management, whenever you encounter such kind of a patient who is having a history of a very severe pulsatile kind of headache for like less than at least for like 4 hours. Okay, they will be sitting in a very dark room, very quiet room, because they have this photophobia, phonophobia. Okay, and they have this history of the zigzag lines, or sometimes any kind of abnormal smell, or anything it could be. Okay, so whenever you encounter this kind of a patient, you will always first give them the NSAIDs. Not available, you can give the patient triptans, the sumatriptans, right? You can give the patient dihydroergotamines. Okay, so these are the acute management. Okay, opioids are generally not given in case of migraine because they have this very less potency. Okay, so you won't give the opioids in case of migraine. NSAIDs, triptans, and dihydroergotamines, they are the initial therapy. For the prophylaxis, you need to first make the lifestyle changes. Beta blockers, okay, anti-epileptics, okay, anti-depression drugs like the amitriptylines, okay, anti-epileptics like topiramate, valproate, they will be given. So beta blockers, anti-epileptic, and antidepressants. Okay, you can also give the patient anti-CGRP monoclonal antibodies because these are the peptides which are responsible for the pain transmission. If you give them the patient anti-CGRP antibodies, you can create this condition also. Okay, so pulsatile pain, one-day pain, unilateral nausea, and disabling type. Always think about the migraine. Most commonly, it would be a female, but it can also seen in the males. A male patient with a facial pain, think about the migraine. Now you can also realize that the same kind of a pain will also be seen in case of one more disease, which is
trigeminal neuralgia.
not a trigeminal neuralgia, it would be a shooting and pain for only short minutes or seconds, not the hours. So not the neuralgia.
CIA,
Yeah, an inflammatory condition that can cause that kind of a pain in the distribution of
giant cell arteritis.
giant cell arteritis, right?
Yeah.
Yeah, exactly. Giant cell arteritis. You can have a jaw pain, you can have a headache, orbital pain, right? Remember, you can have a temple pain that all radiates to the back of your head. That would be a kind of pain seen in the giant cell arteritis. But please note the age of the patient is very important. Migraine will be a young patient. Okay, no new patient who is very old can get the migraine. It is always a young patient who will get the migraine, and you can see the old age patients having a migraine but have a very prolonged history of the migraine generally, right? So no new diagnosis of migraine made in the elderly generally. Okay, and so yeah, whenever it is an elderly patient, you will always think about a giant cell arteritis, but in the young patient, think about the migraine, right? And of course, the pain happens in the episodes. It can like sometimes happen regularly for up to a week, and then the episodes are just over. Then again episodes started. Fever would also be there in case of vasculitis, but not in case of migraines. So other things are also considered, right? Very important. Then you have a tension headache, but that happens bilaterally. So a bilateral pain will be a tension headache pain. Okay, it will be a steady pain, a very dull occurring pain, not a very sharp, not a very pulsatile, but a dull pain. Okay, so a steady band like dull pain, always think about the tension headache. It can happen up to the 4 to 6 hours and it can remain constant for up to a weeks also. Okay. Along with that, patient can also have a tenderness in the paroxysmal muscles like the shoulder or the head or the neck. Okay, treatment includes the NSAIDs, analgesics, or acetaminophen. Okay, for the prophylaxis, you can give the patient amitriptylines and the behavioral therapies. Okay, you have one disorder in which you can get a tension headache along with the muscle pain. If anyone remember, all the depression, muscle pain,
Fibromyalgia.
headache, fibromyalgia, exactly. Okay, so look for that patient. If she's having a fibromyalgia, okay, watch out for that. Other causes of the headache include subarachnoid hemorrhage. We have discussed the worst headache. Meningitis can cause the headache. Whenever you have a high increase in the intracranial pressure, like in case of hydrocephalus, you can get a headache in that. In the neoplasia, any kind of a brain tumor or a metastasis to the brain tumor, sorry, to the brain, they can cause the headache. Giant cell temporal arteritis, like we have discussed, they can cause the headache also, right? Patient can also have the trigeminal neuralgia and they can have the headache-like symptom, but please note that it would be a shooting shock-like pain, unilateral in the distribution of fifth cranial nerve. The pain will only occur for a few seconds. Okay. So, and the triggers could be anything. It could be even a touch on the mouth. It could be chewing, talking, touching, like shaving, anything. It could be, right? So this could trigger the trigeminal neuralgia. Please note that the frequency and the duration of episodes increases with the increase in the time over the time. The frequency and the severity of the disease will increase over the time. So patient will get a more frequent episode, more severe episodes at the time passes, right? Episodes last for only few seconds or up to few minutes, never can be for hours. Okay. So it would be a patient who is doing shaving or like chewing, talking to somebody or anything, and they suddenly started having this electric shock like pain on their jaw, right? Always think about the trigeminal neuralgia. Treatment includes the first line therapy, that is a carbamazepine. Okay. You need to always measure the CBC of the patient whenever giving the carbamazepine because it can cause the aplastic anemia also. Other causes which are not mentioned in the first aid are the chronic sinusitis. In the chronic sinusitis, you can have the facial pain, sometimes a headache, tenderness, along with the nasal congestion, and the discharge will be present. Patient can also have a decrease in the taste and the smell. Okay, please note the taste and the smell, they always go together. Okay, so loss of taste, loss of smell, headache, tenderness, nasal discharge, congestion. Always think about the sinusitis. You can have the headache in case of also. So any doubt on this page?
No, thank you.
No, thank you.
Then you have the movement disorders. Okay, let's go together one by one. So first you have the akathisia, okay, which is the restlessness. You will get a sudden urge to move your leg and you have to move, right? So this is the akathisia, and it generally happens as a as a side effect of the antipsychotic therapy, as an extrapyramidal side effect, right? You also need to differentiate the akathisia with the restless leg syndrome. In case of akathisia, okay, you won't have any kind of a discomfort. It's just an urge for your leg to move and you will move it. Okay, but in case of restless leg syndrome, you will be having a very kind of discomfort while doing that. Okay, we will discuss that later in a second slide. So please note, you have to differentiate between the akathisia and the restless leg syndrome. Okay, so akathisia as a side effect of the antipsychotic therapies as well as a side effects of the Parkinson's treatment. Okay. Then you have the astraxis, which is basically a flapping tumor in these tremors. And if you guys remember the hyperammonia we have discussed, whenever you have a hyperammonia, you can get the astraxis, which are the flapping movement of your hands, right? So hyperammonia is a cause. Second cause is basically the hepatic encephalopathy that can happen because of the Wilson's disease also. Okay. So any case of hepatic encephalopathy can cause the astraxis, like the Wilson's disease, like the hyperammonia, or any other metabolic derangements can cause them. Then you have the athetosis, which are the snake-like slow movements of the fingers. Remember, not the hands, but the fingers. You have the movement. Okay. It happens because of a pathology in the basal ganglia, and it generally is seen in the Huntington's disease. Okay. Then you have the chorea, which is basically a slow movement of your hands, your complete arm, you can say. Okay, one extremity. Sudden, jerky, purposeless movement is lower movement, continuous movement, smooth movement of your one extremity or both extremity. Okay, it could be upper extremity, it could be a lower extremity. You can get a slow movement of your lower limb, you could get a slow movement of the upper limb. Sometimes they can also make some kind of a pattern like a circular motion or an infinity motion or anything like that. Okay, you will call it a chorea. Okay, it also happens because of a pathology in the basal ganglia, generally seen in the Huntington's disease. And also you can see that in the rheumatic fever disease, whenever you have the Sydenham chorea, right? So two conditions for the chorea, Huntington's chorea and the Sydenham chorea. Then you have the dystonia, which is basically a contraction of a muscle group, a group of muscle. And it would be a very painful, sustained contraction whenever you try to move your arm or, or your body part. Okay, against that muscle group, you will have a very severe pain. Okay, and that causes a dystonia. You can call it a neck rigidity sometimes. Okay, that's nothing but just a contraction of your muscle group in the neck. So you will have the stiffness in the neck, right? So a sustained involuntary contractions of a muscle group, we will call it a dystonia. It generally happens because of a side effect of the antipsychotic therapies, the extrapyramidal side effects. You can have the blepharospasms, you can have the torticollis, right? Treatment includes the antispasmodic drugs, the botulinum toxin, because it inhibits the ACH, so inhibit the contraction of the muscle groups. So you can give the patient botulinum toxin, which is having a dystonia, right? Who is having a dystonia. Torticollis happens whenever you got a contraction in the sternocleidomastoid, and as a result, your neck will be deviated at one side of your body. So whenever you try to move your neck, you will have a very severe kind of pain, right? So that is known as the torticollis. Okay. Then you have the essential tumor. Okay, and that happens whenever you maintain some kind of a posture, like holding a pan or holding a glass, okay, or just holding anything. Okay, so whenever you try to maintain a posture, the patient try to maintain a posture, they will get the seizures, the tremors, not the seizures but the tremors, right? And that are known as the essential tremors. Okay, so it happens whenever they're holding on to something, whenever they're maintaining a posture, or whenever they are anxious. Okay, the symptoms will improve after the alcohol use. That is the important part. The symptoms of the essential tumor, they improves with the alcohol use, and that's why the patient always self-medicate themselves with the alcohol. Okay, they can be bilateral, they can be unilateral, and generally this condition is always runs in the family. So a family history you always takes for the essential tremor whenever you encounter a patient who is having a history of tremors, a sudden tremors, right? You will always take the family history of the patient, because that this condition generally runs in the family. They will have the history of alcoholism. They will self-medicate themselves with the alcohol in order to prevent this condition. Whenever they are holding any glass, any pen or anything, they will start having these kind of tremors in the hand. Okay, beta blockers are the treatment of therapy, very important. Okay, primidone is another anticonvulsant drug which can use be for the essential tremor. So two drugs, the beta blockers like the propranolol and the primidone for the essential tremors. Then you have the intention tremors, and that happens whenever you want to make a targetoid movement. Okay, whenever you want to progress towards a target, like holding you want to hold a pen, so you are progressing your hand towards the glass or the pen in order to hold it, and while doing so, the patient started having the tremors. Right, so these are the zigzag motions whenever you are pointing or targeting towards a target. Okay, and that happens because of a cerebellar dysfunction. Okay, as the hand approaches the target, the frequency of these tremors will be increased, and this condition generally is seen in the multiple sclerosis most commonly. So whenever you have a patient of the multiple sclerosis, you can mostly see in the vignettes also that the patient has a history of these intention tremors. And why is that? Because of the demyelination in the cerebellum. Okay, then you have the resting tremors. Okay, the patient will have a suddenly uncontrolled movement of the appendages. They are just sitting, okay, and they suddenly started having these kind of a tremors on their hands. So these are the resting tremors, generally seen in the patients with the Parkinson's. And when they move their hand, the tremors disappear. Okay, you call them a pin rolling tremor also. Okay, at the rest, you are having a tremors. As soon as you move your hand or the extremity, the tremors will be disappeared. Generally seen in the patients with the Parkinson's. You have the hemiparesis. We have discussed that sudden wild feeling movement of one side of the body, and that happens because of a damage in the subthalamus. Because subthalamus are the inhibitory center for the movement, inhibition will be inhibited, so we'll get the activation ultimately. That happens because of a lacunar stroke. Contralateral lesion must be there. Please note. Okay. Then you have the myoclonus. Okay, sudden jerks. Okay, a sudden uncontrolled muscle contraction, you can say. Okay, like the hiccups, like the jerks. Okay, that can be happen with the myoclonic seizure. That can be happen with any metabolic abnormality, like the renal failure, liver failure. It could be. Okay. Myoclonus can also be seen in the Creutzfeldt-Jakob disease, the CJ disease, or the Prions disease. You guys can say it. Okay, myoclonic seizure can also seen in these disorders. And finally, you have the restless leg syndrome. Okay, which is basically seen mostly in the night time. Whenever you want to sleep, you will get a sudden urge to move your leg. Okay, along with that, discomfortness will be there. And when the patient moves their leg, the discomfortness will be over. Okay, causes could be idiopathic, it could be the iron deficiency anemia, it could be the uremia, or it could be the diabetes. Remember these four causes: iron deficiency anemia, uremia, and diabetes. IUD. Okay, so yeah, these. So please know the difference between the Rasselak syndrome and the this akathisia. In the akathisia, you will be having constant movement, sudden urge to move your legs. Okay, so moving your legs, but it is not associated with the discomfortness. While the restless syndrome, it is associated with the discomfortness. Okay, you will have a sudden urge to move, and mostly in the night time, at the time of sleeping, or when you go to bed for sleeping, you will have the sudden urge to move your leg. And if you don't do it, then you will get a discomfortness in the leg. Okay, causes are also important. Akathisia is most commonly a drug cause, a side effect of a drug, and the restless leg syndrome is basically because of a iron deficiency anemia, uremia, or might be the diabetes. Any doubt on this page?
No, thank you.
Okay, now you have the neurodegenerative disorders. What does that mean? You're having a neurodegeneration. That means the atrophy of a part of your brain, damage of the neurons of a part of your brain you're having. We call it a neurodegeneration. Okay, all of these conditions, they have the dementia with them. Okay, as well as and whenever you have a dementia, that means you're having a loss of memory associated with one function loss at least. Okay, so they have a decrease in the cognitive ability, they have a loss of memory. Okay, they have a loss of function with the impact consciousness also. You call it a dementia. You call it amnesia whenever just a memory loss present without any or without any other functional decline, right? You call it this amnesia. If the amnesia is present with any functional decline in the patient, you call it a dementia, right? You must first rule out a depression, because depression is also a very common cause of the dementia. You call it a pseudo dementia. Okay. Other causes should be excluded also, like the hypothyroidism, vitamin B deficiency, neurosyphilis, and the normal pressure hydrocephalus. We'll come to that later in the page. Okay, the normal pressure hydrocephalus, but note that it is also a cause of your dementia. So you must exclude it also first by looking in the MRI of the patient. Okay, so first you have the Parkinson's disease, in which you're having a loss of dopaminergic neurons. And the dopaminergic neurons are basically present in the substantia nigra pars compacta, which is a structure in your midbrain. We have discussed that previously. You will have the tremors, you will have the rigidity, you will have the akinesia or the bradykinesia. That means a slowing of the movements you will get. Okay, you will have the postural instability. Stooping posture generally is there. Shuffling gait is present. Okay, they will vibrate, they will shake too much and then they will move very slowly, and that's kind of a gait you will see in the shuffling gait. Okay, and they have a very small handwriting, and that is known as a micrographia. So a patient who is having a tremor at the rest, okay, rigidity while at the time of movements, okay, they have this kind of a stiffness in their arms, in their limbs. Okay, for the movement, they have a slowing of the movement. They have the stooped posture. Okay, they have the shuffling gait. They're kind of shaking, hold their body, and then moving very slowly, little steps. Right, it is a shuffling gait. You will have a very this small handwriting also. You will call it a Parkinson's disease because of a degeneration of the substantia nigra pars compacta. Okay. MPTP is also a drug that can cause a Parkinson's, and that's why this drug is now banned. Okay. Because this drug was too toxic for the substantia nigra pars compacta. Okay. So you will have a loss of dopaminergic neurons, and you will also have something known as a Lewy bodies. And like I told you, with any of these neurodegenerative disease, you can get a dementia also. Ultimately, with the Parkinson's disease, in the later stage, after 1 or 2 years, patient can also develop a dementia, and you call it the dementia associated with the Parkinson's disease. You call it a Lewy body dementia when the patient get a dementia within 1 year of the Parkinson's. After 1 year, you will call it a dementia associated with the Parkinson's, not a Lewy body dementia. What are the Lewy bodies? These are basically the alpha synucleins. These are the bodies intracellular. Please note these are the intracellular eosinophilic. That means a pinkish deposits or inclusions you will see within the neurons, and these are the alpha synuclein. Okay, please note that the normal, for the normal functioning of your cell, you require these alpha synucleins. They will become abnormal in case of Parkinson's disease. They will start depositing inside the cell, making the making all these inclusions inside the cell. You call it a Lewy body inclusions. Okay. In order to treat that condition, you can directly inhibit the GPI of the subthalamus. Okay, because ultimately you're having a destruction of the direct pathway and a hyperactivation of the indirect pathway in case of Parkinson's. So if you inhibit the indirect pathway, you can have a improvement of the symptoms of the Parkinson's. Okay. And if you want to look for the alpha synuclein, as you can see, these are the inclusions you will see in the alpha synuclein. Okay, these kind of eosinophil inclusions you will see in the alpha synuclein. Any doubt on the Parkinson's disease?
No,
No,
thank you.
thank you.
Okay, good. Now, if you get the dementia within 1 year of the Parkinson's, right, you will call it the Lewy body dementia. Everything is same. Patient is having a Parkinson's, patient is having dementia. It just a dementia occur before 1 year. Okay. And you also see the Lewy bodies in case of Lewy body dementia, just like the Parkinson's. What other features are there? The patient can have a dream enactment, and that is a very important thing you will get with the Lewy body dementia. And that is the REM sleep behavior disorder. Okay, the patient will be having the the loss of inhibition of the muscle groups. As you guys know that in my REM sleep, I'm having this rapid eye movement as well as the loss of all the muscle tones, right? Yes.
Yeah.
In case of REM sleep disorder, the inhibition of these muscle groups does not happen. And as a result, you won't get the paralysis in case of the REM sleep behavior disorder. You call it a dream enactment syndrome also. The patient will have this violent dreams in which he's like kicking and punching. So the patient, so all these person who are sleeping right next to them, they will get the punches, they will get the kicks of the patient. The patient screams while dreaming. They will also remember their dream because these dreams are present in the REM sleeps phase, right? So they will remember their dream, and they will often tell you that they saw this kind of a thief kind of a dream, or someone was trying to kill them, someone was plotting their killing in the dream. So a kind of a violent dream they will see. They will have the kicking, punching history. Okay, they all recall their dreams, right? So this is the REM sleep behavior disorder you will get in the Lewy body dementia. Okay, fluctuating consciousness will be, cognition will be there. Okay, one time the patient was normal, one time they got this kind of a decline. where they have this memory loss and as well as anyone, this functional decline in the patient. Okay, otherwise everything will be similar, just like your Parkinson's. Then you have the Huntington's disease. In the Huntington's disease, you're having a loss of the caudate nucleus. And as a result, the dopamine is increased, okay, and the GABA and acetylcholine are decreased. Okay, inhibiting neurons, GABA is decreasing, dopamine is increasing, and the acetylcholine is decreasing. Okay, it is an autosomal dominant disorder characterized by the trinucleotide repeats of the CAG. Okay, generally the CAGs are present in your DNA normally, but when the number or repeat of the CAGs are increased, you call it a trinucleotide expansion disorder. The number of these trinucleotides are expanding, right? With the successive generations, okay, the number of these trinucleotides will also be increased, and as a result, you will see a phenomena in the Huntington's disease. You call it a anticipation. That means with the successive generation, okay, the severity of the disease will also increase, as well as the time of onset of the disease is decreased. Okay, with the successive generation, you will have the early onset of the disease. Like in one generation, the disease onset was 50 years. In the next generation, the disease onset was only 40 years. And then in the next generation, disease onset was only 20 years, right? Severity was increasing and the onset was decreasing. You call it the anticipation because of increasing in the trinucleotide expansion, right? The Huntington disease, the gene for the Huntington protein is present on the chromosome number 4. And please note that it is an activating type mutation. You will have a gain in function mutation of the Huntington gene, okay, that inactivates the other gene which are responsible for the normal functioning of your brain. Okay, so other proteins are inhibited. You will get a abnormal activation of this protein which are inhibiting the other normal proteins. Okay, patient will get the chorea, they will get the athetosis, the snake-like movement, they will get the aggression. Sometimes they can also get the depression and the dementia, of course. So a patient with a history of this depression, along with some other symptoms like the chorea, you will think about the Huntington's disease. Okay. In this case, you will have the loss of caudate that loses the ACH and the GABA, right? And because the caudate nucleus is present, in the lateral part of your lateral ventricles, you will have the expansion of the lateral ventricles in case of Huntington's disease. On the MRI or CT of the patient, you can see the ventriculomegaly of the third ventricle, lateral ventricles, right? You call it a hydrocephalus ex vacuo. Frontal horns of the lateral ventricles will expand. You will have a high level of dopamine, low level of GABA, and low level of ACH. So a patient with abnormal rapid uncoordinated movement of the extremities, that could be your upper limb, that could be your lower limb, okay, along with any history of psychosis like the aggressive behavior, okay, irritability, or sometimes a depression, okay, and this kind of a history present in the family members, you will always think about the Huntington's disease. Please note the disease has 100% penetrance. Okay, very important to note. And does anyone know why this expansion of the trinucleotides happen? We have discussed that in the biochemistry section.
Mismatch, like there's a mismatch because of
Not kind of a mismatch.
Is slipping?
What?
DNA slippage?
Yeah, exactly. DNA slippage, yes. DNA slippage phenomenon due to which you will have an addition or deletion of the nucleotides, right? In this case, you're having the addition of these trinucleotides repeats. Okay? The DNA slippage is responsible for the expansion repeat disorders. Any doubt on the Huntington's disease?
I have one question.
Yes.
What is the meaning of ex vacuo in ex vacuo ventriculomegaly?
You're having this kind of a vacuum thing in the brain. Okay, you're having the loss of all these neurons. As a result, the space is present in the brain, right? This space will be taken up by these ventricles. So it is not a true it is not a true ventriculomegaly. It is not happening because of the increase in pressure or increase in fluid of your ventricle. It just the space was present in your brain, and that space was taken up by the ventricles, right?
Okay,
So no increase in pressure.
So we won't get hydrocephalus over here, right?
Yeah, it is kind of a hydrocephalus, but not a hydrocephalus type. You can say it like that,
Yeah, I get it.
You're not having the this high much CSF in the brain. CSF is absolutely normal.
Yeah.
It's just having a lot of space which is covered by the ventricles, right?
Okay, yeah, got it now. Thank you.
Okay, now you have the Alzheimer's disease. Okay, and that happens because of accumulation of something known as the beta amyloid core. Okay, very important. So what you will see, actually what was happening, first we have the amyloid precursor protein, and these are responsible, these are required for the normal functioning of your neurons, of course. Okay, the amyloid precursor proteins are required for the normal functioning. You have the alpha disabling of this protein and the beta disabling. If the alpha dissociation happening, it will be absolutely normal. Okay, the protein will be degraded and you won't get any symptom. But if the beta degradation of this amyloid precursor protein happens, you will get something known as the you will have the structure which becomes a beta plated. Okay, you have this protein becoming the beta plated, and now uh, it become resistant to the degradation, and as a result it will start accumulating outside the neurons. Okay, and because they're accumulating outside the neurons, they will call the inflammation happen, that will destroy the neurons. Also you will have the neuronal death, and that causes the Alzheimer's disease. Okay, the gene who is responsible for this amyloid precursor protein, it is located on the chromosome number 21, and that's why in the Down syndrome patient can have the Alzheimer's disease also, early onset of Alzheimer's disease. Okay, and the Alzheimer's disease, you're having a loss of ACH only. Okay, so one of the treatment you can give is to increase the patient's ACH levels in the brain. That means by giving the patient acetylcholine esterase inhibitors. Okay, now this condition can have the associations also. If you are a person who is having the apple apoprotein E2, and does anyone remember the function of this apple apoprotein E?
For exit of VLDL and chylomicrons from the blood into the liver.
Exactly. Okay, for the uptake, you can say for the uptake of the chylomicrons and the VLDLs by the liver, you need the apple apoprotein E. Okay, this apple apoprotein has many variants. If you're a person who is having an apple apoprotein E2, that means you have a decreased risk of developing the Alzheimer's disease. And normally the Alzheimer's disease is a disease of old age only. You will get the disease only after 60 years of age. So we are talking about the 60 years. That means after 60 years, if you have the apple apoprotein E2, you won't get the disease. If you're a patient who is having an apple apoprotein E4, that means after the 60 years, you will have a very increased risk of developing the Alzheimer's disease. Okay, then you have certain mutations in which you get the early onset of the Alzheimer's. That means before the 60 years of age, you will have the mutation in the APP, in the presenilin 1, presenilin 2. Okay, and these are the familial forms. The patient generally have the familial history. Whenever you encounter a patient who is having an early onset of Alzheimer's as well as a family history of Alzheimer's, always think about these three mutations: the APP, presenilin 1, presenilin 2. Okay, they will have an early onset of Alzheimer's before age of 60 years. Okay, what you will get? First, you will have the memory loss, and that is the most common symptom patient will present you with. They will first present you with the short-term memory loss, and then the long-term memory loss. Initially, they start forgetting about what's happening to them, right, in the in this present future. Then they stop remembering about their neighborhood. So basically, they lost in the neighborhood sometimes. Okay, they just go on a walk and they forget to come back. Okay, so and with the disease progress, they stop forgetting about all their relatives, then their name, then their family also, right? And at the end, they stop forgetting. They start remembering. They stop remembering anything about them, right? So first, a short-term memory loss happened. Okay, they stop recognizing new faces. Okay, then the long-term memory loss happens. Okay, and at the end, the patient will get the death. So in the later course of the disease also, you will get the functional decline, and that's why I call it dementia. Okay. So first you only have the memory loss, and then the long-term memory loss along with the functional decline of the patient. They cannot remove their clothes. They cannot wear their clothes by themselves. They cannot bathe themselves. They cannot urinate. They cannot micturate. They cannot do anything on their own, right? They need the assistance of another person while doing the normal course. Okay. normal household chores, right? So that's kind of a functional decline you will see in case of Alzheimer's disease. Okay. Patient will get a loss of execution functions like the planning. They will have a loss of visuospatial functions, and that's why they will lost in the surroundings sometimes. They forget to come back home. They forget their route for the home. Okay, so they will get lost in the surrounding, and you will call it a loss of visuospatial functions. They will have a loss of motor functions, so they will get a frequent falls also. Okay, you're having a diffuse cortical atrophy in case of Alzheimer's disease. So whenever you do the MRI of the patient, what you can see a diffuse cortical atrophy. Okay, when the patient dies and you do the biopsy or the postmortem autopsy of the patient, what you will see is the cortical atrophy. Okay, and especially the disease is present in the hippocampus, and that's why you have the memory loss first because of a damage in the hippocampus. And as you can see, this is the hippocampus of a normal patient. Just middle to your hippocampus, what structure you have? Zoom in. You have the hippocampus here. Okay, middle to your hippocampus, what structure you have?
Amygdala.
Amygdala, yes. And middle to them, what structures you have?
Mammillary bodies.
Mammillary bodies. And just above your mammillary body, just below your third ventricle?
Hypothalamus.
Hypothalamus. Lateral to your hypothalamus, just below your thalamus, what structures you have? Subthalamus. Yeah, the larger one structures you can see here, these are your thalamus. Just lateral to your lateral ventricles, what structures you have?
Caudate.
Caudate nucleus. And
Internal.
see here,
Lentiform.
the lentiform. Lentiform. The lateral part of the outer part of the lentiform is what nucleus?
Putum.
Putum, and then
Globus pallidus.
Globus pallidus.
Externus, and then the internus. Okay, so now you remember every part of the cross section of the brain, right?
Yeah.
Okay, so as you can see, you have the degeneration of the hippocampus in case of Alzheimer's disease. As you can see here, this is kind of a degeneration you will see, right? The hippocampus is dying. Okay, so that thing will be seen in the Alzheimer's disease on the autopsy. Okay, when the patient dies with the Alzheimer's, you do the autopsy and you will find this kind of a thing there, right? You will have the narrowing of the gyri and the widening of the sulci. Sulci become very much prominent, widened, and the gyri become very much narrower. That you can also see on the MRI of the patient and as well as on the autopsy, on the cross-examination of your brain. Okay. Now, that's the thing about the MRI or the cross-examination. What about the microscopic examination? Well, you can see two things. Okay, one are the extracellular plaques, and second are the intracellular plaques. The extracellular plaques we call are the senile plaques, which are basically the plaques of amyloids. Okay, the amyloid precursor protein was there, and whenever it got a beta cleavage, it will become very resistant to the degradation. It will start accumulating outside the cell, and when it start accumulating outside the cell, it becomes the senile plaques. Okay, it is the A beta type of amyloid. Okay, and because this amyloid deposit around the blood vessel, you can get known as the amyloid angiopathy. It will be an old age patient who is having a recurrent history of the hemorrhages in the brain. Okay, recurrent smaller hemorrhages in the brain. Always think about the Alzheimer's disease. Okay, so they have the intracranial hemorrhage because of that. Multiple histories will be there. So it would be a patient who was initially normal, then they got the paralysis of one limb, then they got a paralysis of another limb. Okay, then the paralysis of their face, then the sensory loss of their face. So stepwise functional decline will be there in case of this intracranial hemorrhage, right? So this kind of a history will be there in case of amyloid angiopathy. Okay, now what you will see are the amyloid precursor protein, their plaques on the outside of the cell. You call them the senile plaques, as you can see. And why does these plaques found in the gray matter?
Because the proteins are degraded normally in the cell body.
Yeah, around the cell body, right? So these plaques will be seen in the periphery portion or the cortex of the brain, which is the gray matter, right? As you can see, these are the extracellular plaques. Okay, all these kind of plaques you will see outside because it's a cell. These are the outside plaques. Okay, you call them the neuritic or the senile plaques, which are seen in the Alzheimer's disease of the patient. Then you have the intracellular plaques, and you call them the neurofibrillary tangles. Okay, you have the tau protein. Normally the tau protein was hyperphosphorylated. Okay, and this protein, again, just like the alpha synuclein, just like my amyloid precursor protein, this protein is also required for the normal functioning of the cell. Now, when this protein becomes hyperphosphorylated, that means too much phosphate attached on this protein. Okay, now this protein becomes dysfunctional. Okay, and what you will get are the insoluble cytoskeleton, because this protein is a part of the cell cytoskeleton. That means the microtubules. In order to to transmit any substance from my cell body to my axonal ends, you need the tau protein also. Now, when this protein died, the microtubules will be damaged. Okay, and as a result, what you will get are the tangles of this tau protein. Okay, so on the electron microscopy, you will see the degradation of the microtubules of the axons, and you will get a deposition of these tau proteins within the cell body of the patient. As you can see, these are the intracellular plaques. Okay, so both the extracellular as well as the intercellular plaques will be seen on the biopsy of the patient. And when you can do the biopsy of the brain?
After death.
After the death.
After the death. Exactly. When you're performing the autopsy, you will see these plaques only, right? So remember, Alzheimer's patient, chromosome number 21, amyloid precursor protein, the beta platelet sheet configuration, it will become resistant to degradation. Patient initially have the short-term memory loss, then they have the long-term memory loss along with the functional decline. They cannot wear their clothes, they cannot remove their clothes, they need assistance in every day-to-day activity of their life. Okay, then finally they have this infection and they will die at the old age. Okay, if you're having a this apolipoprotein E2, that means you have a decreased risk of old age Alzheimer's. If you have a E4, you have an increased risk of old age Alzheimer's. Early onset of Alzheimer's will be seen in the Down syndrome, in the amyloid precursor protein mutations in the gene, in the presenilin 1 gene mutation, in the presenilin 2 gene mutations, right? So you will have the diffuse cortical atrophy. You will have the diffuse atrophy of the hippocampus, right? You will have the expansion of these ventricles. Hydrocephalus ex vacuo diffuse type of ventricle megaly will be seen, of course. On the biopsy, on the MRI, again, you can have the widening of the sulcis, narrowing of the gyri. On the biopsy of the patient, you can have the extracellular plaques as well as the intracellular plaques. In order to treat the condition, you can give the patient NDMA activators, and you have to decrease the because in the condition you're having activation of the NDMA receptors and the inhibition of the ACH neurons. The treatment includes the NDMA inhibitors like the memantine and the acetylcholinesterase inhibitors like, remember the two drugs?
Galantamine and rivastigmine.
And donepezil also. Donepezil, rivastigmine, and the galantamine, right? These three drugs for the Alzheimer's disease treatment. Now, any doubt on the Alzheimer's disease?
Could you please explain the association between tau proteins and microtubules? I couldn't understand that.
Actually, these tau proteins are required for the normal assembly of my microtubules. Okay. So if the tau proteins are not there, the microtubules won't form. They will dissociate. They will destroy it, right?
Yes.
And when the cytoskeleton of my cell is destroying, the cell will die again, right? It cannot transport anything. All these things will start accumulating inside my cells, right? Like this tau protein for itself, it will start accumulating within my cell also, right?
Okay. Yeah.
So these things you will see. You can also see the the Hirano bodies, okay, and these are the eosinophilic inclusions found in the hippocampus. Okay, intracellular eosinophilic inclusions found in the hippocampus, you call them the Hirano bodies. These are also seen in my Alzheimer's disease. Okay. And finally, you have the frontotemporal dementia, in which you have the atrophy. As the name suggests, it includes the frontal lobe as well as the temporal lobe. And I told you already that the frontal lobe is connected to the temporal lobe for the behavior regulations, right?
Yes.
And that disease is known as the Pick's disease. You will have the atrophy of the frontal lobe as well as the atrophy of the temporal lobe. Patient will get a first change in the behavior, in the personality of the patient. Then they get the memory loss. Okay. But at the time when the patient presents you to the department, they will always present you with the change in behavior. At that time, they do not get the memory loss. An Alzheimer patient, they will always present you with the memory loss first, and then they have starting, this behavior irregulations or, this functional decline. In case of the frontotemporal dementia, you first have the behavioral dysregulation, right? So they will present you with the change in behavior. Once you diagnose them, they started having this, the loss of memory, and then the functional decline will be there. Okay, so it was a patient who was initially very much, humble, very much polite, and now he become very much aggressive. Chronically, he become very much irritable. Hypersexuality could be there, hyperphagia could be there, hyperorality could be there, right? All these kind of a change in behavior present in the frontotemporal dementia. In the later course of the disease, once you diagnose the conditions, of course, the patient will get the loss of memory. They will get a functional decline also, just like my Alzheimer's. Okay. So please note, at the time of diagnosis, only the behavioral change was present. Okay, you call it a frontotemporal the degeneration will be present. Okay, just like my Alzheimer's, you will have the hyperphosphorylated tau protein again. You call them the PIC bodies. Okay, and you also have something known as a ubiquitinated TDP43. Now they stopped giving you the PIC bodies, but instead they give you this ubiquitinated TDP43 protein. Okay, and you do the silver staining in order to identify these PIC bodies or the TDP43. Okay, so if you hear some kind of a test mentioning the TDP43, or you see the example, the option mentioning the TDP43, you will think about the frontotemporal dementia again. Okay, just like my Clever-Bush syndrome, you can have the hyperphagia, hyperorality, hypersexuality, aggressiveness will be there, right? All these things will be there. The patient will also have a this aphasia. Minimal verbal output will be there in the patient. Okay, you ask them something, they will just reply you with yes or no, and they tell you that they're absolutely normal. Okay, it's just their partner or their person is just overthinking about them. They're absolutely normal, right? But they have a very minimal verbal output. This is also a feature of your frontotemporal dementia. Any doubt?
No, thank you.
So how you can differentiate on these conditions? Whenever you got a movement disorder, tremors, slowing of movements, along with the loss of memory, think about the Parkinson's. Whenever you have some kind of a chorioid movements, these movements of your hands or your legs, the circular motion or the rectangular motion, or this continuous kind of movements of hands and the fingers, right? You will think about the Huntington disease, depression, aggression, and and the dementia will also present in Huntington's. If you get only the memory loss first and then the functional decline later in the disease, think about the Alzheimer's. If you get the personality change first, then the functional decline or the loss of memories later, think about the frontotemporal dementia. Okay, and that is about the cerebral amyloid angiopathy. It is because of a beta amyloid deposition around the arteries. Patient will be more than 60 years. They will have a recurrent occipital and parietal lobe hemorrhage. Okay, that means patient can get the contralateral dyshomonymous okay, because of a damage in the occipital lobe. You can have the chordentopia because of a damage in the parietal lobe. Okay, contralateral hemisensory loss will be there, paralysis will be there, right? So all these symptoms will be present. On the MRI, you will see the hyperdense region as well as the hypodense region, right? Hypodense region signifying a previous stroke, hyperdense region signifying a new stroke. Age will be more than 60 years. You will always suspect the cerebral amyloid angiopathy. Okay. Now, any doubt on this page?
No, thank you.
No, thank you.
We have discussed already about the Lewy body dementia. Okay, you will have a Parkinson's, and within 1 year, you develop the dementia. Patient can also have something known as the dream entrapment syndrome, which is also known as a REM sleep behavior disorder. You will have the punching, kicking movement because of loss of inhibition of the muscle tone in the REM sleep. You have the vascular dementia that happens because of a stroke. Patient will get a repetitive strokes, and because of that, they will get a functional decline. They will get a paralysis, they will get a sensory loss, and along with that, patient will also get the dementia, the loss of memory, right? So it would be a patient having a stepwise decline. That means, like, say, if I draw the graph of the patient, Right? In like say in case of a normal patient, the level of activity was this. And this is my patient very initially. They will get one episode of a stroke. Okay. And please note, it is a ischemic stroke. Okay, it is a ischemic stroke, not a hemorrhagic stroke. If you're getting a repetitive episodes of the hemorrhagic stroke, think about the cerebral and myeloid angiopathy. If you got a repetitive episodes of ischemic stroke in old age, think about the vascular dementia. Patient get one stroke, they will get a loss of senses. Okay, they will get some kind of a paralysis or any focal neurologic deficit along with the dementia. Like this kind of a decline was there. Then they're normal, right? They're functioning like at this level. Then they get another episode of this stroke. The function level will again decline. They will again start working on this level. They will again get a decline. Again that. So as you can see, stepwise decline was occurring in the patient, right? So a stepwise decline, the cognition ability will be seen. So a patient who is having a repetitive history of the focal neurologic deficits, on the MRI, you see only the hypodense lesion, right? They have this the dementia, also loss of memory, functional decline always, and the memory impairment occur in the very late course of the disease. Okay, so dementia along with the focal neurologic deficits, think about the vascular dementia. Okay, and then you have the Creutzfeldt-Jakob disease. And whenever you think about this disease, I want you to think about the vampires or the zombies, not the vampires, but the zombies. Okay, whenever zombies eat a person or scratch a person, that person will also become the zombies, right?
Yeah.
These proteins, the proteins, the prime proteins in the CJ disease are working just like that. Whenever the protein become a beta plated sheet, you have the prime proteins in your body, and they're required again for the normal functioning of your body. Okay, they're found in the brain as well as outside the brain, and we're talking about the prime proteins found in the brain, right? So they have the normal PRPC configurance. When they become beta plated sheet, just like the amyloid, they become resistant to the degradation. Okay, they will become PRPSC. Okay, and whenever this kind of a prime protein, these mutated prime protein, when they touch the normal prime protein, they will convert this normal prime protein into the mutated one. Regarding my point, just like the zombies.
Yeah.
They touch a normal protein, they will convert this normal protein into the prime protein. And as a result, the number of these prime proteins is start increasing. Okay. At the time of diagnosis of the CJ disease, the patient will die within 6 months. This disease is so much rapid that once the patient was diagnosed, the patient will die within 6 months of the disease. Or maximum they can survive up to a year. Okay, but generally they die at the 6 months. Patient will have a history of myoclonus, that means sudden repetitive jerks of their hands, not the movements, but the jerks. Okay. And these are the high frequency jerks you will see. Okay. These are the myoclonus. So a myoclonus dementia will be there. That means a loss of, this memory as well as a loss of functional decline will also be seen. Okay. Functional decline along with the loss of memory, along with the myoclonus. Think about the CJ disease. Okay, you have the increased 14-3-3 protein in the CSF. Okay, and that protein promotes the apoptosis of the neurons. Because of this increase in the PRPC, okay, they causes the death of the neurons because of this 14-3-3 protein. And because of the death, you can see the spongiform cortex on the biopsy of the patient, and that is a vacuolization without the inflammation, because it is a apoptosis, not the necrosis. So no inflammation was there. Okay, it just because of deposition of these beta-plated sheet proteins around the neurons. Okay, they will activate the apoptotic pathway. The 14-3-3 protein will cause the apoptosis of the neurons that you can easily see on the CSF. Okay, spongiform cortex will be C. Okay, now any doubt on the CJ disease?
Could you once again explain vacuolization without inflammation?
See, you're having the apoptosis of the cell, right? Not the not the necrosis. So no inflammation will be seen, first thing, right? Now, because of the death of the neuron, the space which was occupied by the neuron will be that will be like gone. This neuron will be gone. So the space will be there, right?
Okay, yeah.
So it will appear as, this vacuolization in the brain, right? You will have the spongiform cortex, a sponge-like appearance of the cortex. Literally, you will see lots of holes in the brain, right?
Yeah. Okay, thank you.
And that's because of a atrophy or a loss of neurons in that part. Okay, so that's about the CJ disease. Please note, diagnosis within 6 months or up to a 1 year, patient will die. Any doubt on this page?
No, thank you.
Then you have the idiopathic intracranial hypertension. As the name suggests, the causes are always idiopathic. Okay, but this condition generally seen in the females. They have this intracranial hypertension. That means an increase in the intracranial pressure you will see in the patient. Okay, and because of the this increase in the intracranial pressure, the patient will get the headache. Okay, and headache occurs whenever they try to lift something. Whatever the condition increases the intracranial pressure, that means sleeping with their head down and the feet or the toe above, they will get the increase in intracranial pressure. They will get the headache. Because of the valsalva, they will get the headache, right? While lifting anything, they have to increase the intracranial pressure, so that can cause the again pain, right? So valsalva, coughing, bending forward, lifting objects, upside down movement, the posture, they will all cause the headache in the patient. Because the intracranial pressure is rising, this pressure will transmit via the cranial nerve 2. You will get the edema of the cranial nerve 2, and that calls the papilledema. Okay, you will see the blurring of the margins of the optic disc, and this is the thing you will see in the papilledema. Okay, the blurring of the margins of the optic disc you will see in the papilledema. Patient will have the blurring of the vision also. Visual field defects can also be there, right? On the lumbar puncture, you will see the increased opening pressure, and once you do the lumbar puncture, patient will have the improvement of the symptoms also. You will have a temporary headache relief, right? Now, the risk factors includes a mnemonic, which is the toad, right? You have the tetracyclines, obesity, vitamin A, and danazol. If you guys go back to the biochemistry, we have discussed, the side effect of having an excess vitamin A, and one of the side effect was the headache, right?
Yes, yes.
And that's why you will get the headache, because of increase in the intracranial pressure. If you get the venous thrombosis, like we have discussed previously, you can get the intracranial hypertension also in that case, right? So remember, it would be an obese patient, a very young patient of reproductive age, who is on the vitamin A therapy, or can never be, doesn't matter. Okay, but this classic scenario will be a obese patient who is very young. Okay, they're having this episodic history of the headaches whenever they try to lift something, whenever they bend forward or upside down. They will have the increase in the pressure. They have the blurring of the visions also. Visual field defects could be seen. On the examination of your retina, that means on the fundoscopy, patient can have the blurring of the optic disc margin, signifying the papilledema, right? On the lumbar puncture, the patient will have an increased opening pressure. And once you do the lumbar puncture, patient will have a relief of headache, right? That are all the thing you will get in the idiopathic intracranial hypertension. And we also call it a pseudotumor cerebri. Okay. Treatment includes, of course, a weight loss, acetazolamide, and if you are taking one of these drugs, you must inhibit these drugs, right? And yeah, fenestration surgery can also be performed. You will make some holes. Okay, you have this nerve sheet. Okay, in the eye you have this nerve sheet. Okay, you make holes so that a drainage of the fluid could be occurring. Okay, and that's how you will cause a decrease in the papilledema. Okay, by making some holes in the optic disc. Okay, in the optic sheet actually. Okay, so that's about the idiopathic intracranial hypertension. Any doubt?
No, thank you.
No, thank you.
Now comes the hydrocephalus. That means the expansion of your CSF volume. You will have an increase in the CSF volume, and because of the increase in CSF volume, you're having a ventricular dilation, because in the ventricles you have the CSF, right? So what you will see is the ventriculomegaly. And like I told you, you have a very limited space in your cranium, which is completely occupied by your brain and your ventricles, right? So whenever the ventricles expand, because the space is very limited, patient will have an increase in the intracranial pressure, right? And the herniation of brain sometimes can also happen because of that. Okay. Now you have two type of hydrocephalus. One is the communicating and second is the non-communicating. The communicating one happens whenever you have a decrease in the absorption of the fluid, the CSF, by the arachnoid granulations. That can be happen once by the communicating hydrocephalus and second by the normal pressure hydrocephalus. Please remember the pathology of both the disorders is a decrease in the absorption of the CSF by the arachnoid granulations. In case of communicating hydrocephalus, you're having a decrease in the absorption because of a scarring or a fibrosis in the arachnoid granulations, and that can be happened after the meningitis. That can be happened after the subarachnoid hemorrhage. Remember?
Yes, yes.
So in
Yes.
the meningitis, in the subarachnoid hemorrhage, you can have a scarring of the these granulations, and you will get a loss of absorption of the CSF. The CSF will be increased. You will get a diffuse ventriculomegaly. You will get the papilledema again. You will get the herniation of the brain. Symptoms will be acute in the onset. Very important. You will get an acute change in the mental status, seizures, headache, focal neurologic deficits could be there because of the herniation. Some other structures could be compromised. You will get the focal neurologic deficits, papilledema, blurring of the visions, everything would be there, right? Because of an increase in the intracranial pressure. Second, you have the normal pressure hydrocephalus. Pathology is same. You will have a loss of absorption of the fluid by the arachnoid granulations, but this loss of absorption happens after a very chronic time. Okay, and in that time, the ventricles will have the time to expand slowly and slowly, so that the pressure inside my ventricles will be normal. Okay, now because of the loss of absorption, this thing happens with a very uh, with a very large duration of the time, with a chronic duration of the time, and that's a result. The ventricles will expand, but the pressure won't rise. So that's why the name normal pressure hydrocephalus. Okay, you're having a loss of absorption. Okay, but because this damage happens very slowly, it will ventricles will get that time to slowly acclimatize to this pressure. So the pressure inside the ventricles will be absolutely normal. You will get a diffuse ventriculomegaly. Okay, and that happens because always in the elderly. Okay, now as you can see, if these are your ventricles, okay, and if that is a normal person, okay, let's study this. If these are the ventricles, as you can see, the ventricles are expanding, right? You have this internal capsule, right, in that part, right?
Yeah.
Yes.
And in the internal capsule, you have some fibers on the corona radiata, okay, and these fibers will become distorted because of the expansion of the ventricles. And when the fibers get distorted, what you will get are the urinary incontinence, okay, the gait abnormality, will get a magnetic gait. Okay, the patient will move with all the feet sticking to the ground. Okay, while moving, their feet will rub against the ground. Okay, you will have this magnetic gait, and that's because of the coronary radiata expansion, stretching. You will also have the cognitive decline, that means a dementia. So a classical triad of the dementia, okay, a magnetic gait, and the urinary incontinence. Think about the normal pressure hydrocephalus. You also remember them by the wet, wobbly, and wacky. Although I didn't need that, just remember the triad: dementia, magnetic gait, and the
Urinary.
dementia, magnetic gait.
Urinary
Urinary
incontinence.
incontinence. Yes, these three things will be happen in the normal pressure hydrocephalus. You will have a diffuse ventriculomegaly without any central widening, because a diffuse ventriculomegaly with a normal pressure can also be seen in the Alzheimer's, right?
Yeah.
Yeah.
So don't confuse this with the Alzheimer's, because Alzheimer's is again an oldest disease. You will have a dementia also in case of Alzheimer's, right? But in the Alzheimer's, the major complaint when the patient present you was the memory loss. And secondly, you won't have any cycle widening in that case, right? In case of normal hydrocephalus, right? So yeah, and if not the corona radiata, they can also give you the name, which is the descending cortical fibers. Okay, these corona radiatas are the descending cortical fibers, right? So either they give you the corona radiata in the name, or they can give you the descending cortical fibers. Both name you must remember. Okay. Now, any doubt on the communicating hydrocephalus?
No,
No.
thank
Okay.
you.
Now you have the non-communicating, or you can say the obstructive hydrocephalus, in which you're having a the obstruction in the drainage of the CSF. Okay, you're having an obstruction in the drainage of the CSF in case of non-communicating hydrocephalus. Okay, that means the blockage could be there in any pathway. Okay, the foramen which is connecting your third ventricle with the lateral ventricle, it can be affected. The foramen Monro, right? The cerebral aqueduct stenosis could be there, which prevents the drainage of the fluid from the third ventricle to my fourth ventricle, right? The foramen of Lushka or the foramen of Magendie can be obstructive, and as a result, the ventricles before the obstruction, proximal to the obstruction, they will dilate. Like if you get a dilation of your third ventricle and the lateral ventricle, you can think about the cerebral aqueduct stenosis. If all the ventricles are dilating, you can think about obstruction in the foramen of Monro. If you're having a dilation of the lateral ventricle, you can think about the obstruction in the foramen of Monro, right? Yeah. Okay. If the diffuse ventricles expansion will be there, you can think about the Magendie or the Lushka. Okay. So this non-communicating hydrocephalus, that's why the name, because our ventricles are not communicating with each other, that's why the name non-communicating hydrocephalus. It is really a blockage in the CSF circulation that can be happen most commonly because of a tumor. As you can see, this is a MRI of a child. They're having this tumor which is obstructing the flow of the CSF from my ventricles, right? And what kind of a tumor can do that?
Ependymoma.
Ependymoma. Exactly, ependymoma can do that. Okay, any stenosis in the cerebral aqueduct, it can do that. Okay, any blockage in the Monro by a tumor, it can do that, right? So you will get this kind of a thing. They will tell you that only limited number of ventricles are expanding, not the every ventricle. Rest of the ventricles are normal. Okay, so that's why you know the patient is having a non-communicating hydrocephalus. Okay, then we have the hydrocephalus mimics. Okay, and that is the ex vacuo ventriculomegaly, and that happens because of the atrophy of any portion of the brains, and as a result, if the atrophy happens to a structure which is surrounding the ventricles, okay, you can have the expansion of the ventricles because of that, right? So it will so in the MRI of the patient, it will be appear as the ventricles are expanding, which is true, of course. So the ventricles are expanding, but it is not because of the over accumulation of the CSF, but because of loss of the surrounding neurons. Like in case of Alzheimer's disease, you will get a diffuse ventriculomegaly. In case of HIV-associated dementia, you're having an atrophy of the neurons, you will get the ventriculomegaly. In the Pick's disease, it will be a frontotemporal dementia, so we'll get the ventriculomegaly of the frontal horn of the lateral ventricle, right, as well as a third ventricle. In the Huntington's disease, you'll be having a ventriculomegaly of the little ventricle only. The intracranial pressure in that case will be absolutely normal. Okay, and that's how that's why you need to differentiate it with the normal pressure hydrocephalus, and that could be done by looking at the triad of the patient. Okay, the urinary incontinence, dementia, and the magnetic gait will help you determine the cause, right? So the NPS triad won't see in case of hydrocephalus ex vacuo. As you can see, there's a lots of atrophy of the brain happening, right? And because of this atrophy, okay, these ventricles are expanding, as you can see, right? So this is a ex vacuo hydrocephalus. Now tell me, any doubt on this page?
No.
No, thank you.
Okay, so I think we should take a short break
Yes,
and then we will continue. After the break, we'll discuss the multiple sclerosis and other demyelinating diseases. Okay.
sure. Thank you.
Okay, so we have finished up to the hydrocephalus. We have discussed three types of hydrocephalus: communicating, non-communicating, and hydrocephalus ex vacuo, right? In the communicating, you have a decreased absorption of the CSF by the iconic granulations. In the non-communicating, you have an obstruction in the flowing of the CSF. In the ex vacuo, you're having the atrophy of the brain, and as a result, ventricles expand. Now let's discuss all the demyelinating disorders, and the first one is the multiple sclerosis. Okay, in the multiple sclerosis, you're having an autoimmune reaction against the oligodendrocytes, those cells which are forming the myelin in the central nervous system, and as a result, you will have a demyelination in the central nervous system. And as you can see, you will see these kind of a demyelinating plaques in the multiple sclerosis. Okay, now because of the demyelination, you have a decrease in the saltatory condition. We have discussed that. Okay, how the myelin causes alternating conduction is by the these nodes of NVS, if you guys remember, right?
Yes.
And what channels are present in a very high concentration at node of NVM?
Sodium channels.
Sodium channels, yes. Now, because of the demyelination, you're having a decrease in the impulses transmission, speed of the impulse transmission. Because of a loss of myelination, you can have a decrease in the space constant, right?
Yeah.
Does remember?
Yeah.
This
Yeah.
is space constant, time constant, yes. So you have a decrease in the space constant and an increase in the time constant, and as a result, the velocity or the speed of line of conduction is decreased. You will get a optic neuritis. Okay, it is a highly associated feature of my multiple sclerosis. Okay, the most common presenting complaint of the patient was optic neuritis. Whenever you encounter them, they will have a pain while movement of the eyes. Okay, they have a loss of vision, as well as whenever they move their eye in any other direction, they will have the pain. Okay, they also have the Marcus conpupil. Okay, very important. uh, in this condition, whenever you shines the light in the normal eye, both the eyes will constrict, but when you shine the eye in the abnormal kind of eye, the eyes will dilate instead of constricting, right? We'll discuss that later, don't worry, the Marcus conpupil, but it is a highly associated feature of the multiple sclerosis. Okay, you will get the brainstem or the cerebellar syndromes. And if you guys remember, I told you about the intention tremors, right? Whenever you move your hand towards this target, you will have the tremors, right, while doing that. So this is a very highly characteristic feature of the multiple sclerosis. You will get a diplopia, ataxia, scanning of the speech will be there, broad-based gait will be there. Why broad-based gait?
Loss of proprioception.
Yeah, loss of proprioception, and also the vermis is very important. Loss of vermis, okay? Cerebral vermis can cause that. Okay, you will also have the nystagmus, and this is because of the intranuclear ophthalmoplegia. You guys remember what structure damage in intranuclear ophthalmoplegia?
PPRF.
What?
PPRF or the medial longitudinal fasciculus.
It's not the PPRF, it's the MLF, right? The MLF got damage in the internuclear ophthalmoplegia. As a result, whenever you try to move, and please note it is a bilateral, okay, more than the unilateral. That means whenever you try to move your eye in either of the direction, the this medial rectus won't contract, right? So if you want to move the eye in the right sided, okay, the eye on the right side will constrict, it will go in the right direction, but the left sided eye will remain normal. Okay, it won't move. Whenever you want to move the eye in left direction, the left sided eye will move, okay, literally, but the right sided eye will stays like that. And as a result, this nystagmus happens in the opposite direction, in the order of, in the direction of this correction, right? You have the nystagmus. So internuclear ophthalmoplegia will be there. You will have the pyramidal tract demyelination that can cause a weakness and the spasticity, right? You have the spinal cord syndrome, and it will be an electric shock like pain, okay, whenever the patient causes the neck flexion. With the neck flexion, patient will have the shock like pain, okay. And you will also have one thing, because whenever you have the increase in temperature, the inflammation always increases, and this condition is true for every inflammation, okay, every autoimmune disease, including your myasthenia gravis. Whenever you have an increase in temperature, the symptoms will got worsen, okay. So whenever the patient got increase in body temperature, like during a hot bath or the exercise, the patient will have the exacerbations of the symptom, okay. Patient will also have the neurogenic bladder. They will have this, either they can got the incontinence, okay, or they can cause the hypotonia of the bladder, okay. Both things can happen, okay. Either the retention of the urine can happen or the incontinence can happen, okay. You will also have the paraparesis, loss of senses will be there, right? And symptoms will be relapsing and remitting. That means the symptoms always present in the episodes. Okay, it will be a young patient, and please note, always gonna be a female in the step one, a young female who got a episodic symptoms. The symptoms present for like 1 month or 2 months, then the symptoms got resolved, and after 1 year or 2 years later, the patient again starting having these kind of a symptom. So they always give you a previous history of similar episodes, right? And that's how you know that symptoms are relapsing and remitting. And then you think about the multiple sclerosis. It is a type 4 hypersensitivity reaction, if the step one asks you, okay. And the low vitamin D levels and the smoking are risk factors of the multiple sclerosis. Okay, so what findings you can expect? These are the symptoms. I've discussed the pathology. We have discussed what the multiple sclerosis is. We have discussed all the symptoms. Okay, now what are the findings you will get on the examination? Okay, so first you do the CSF examination. In the CSF you will have an increased protein, and the increased protein is because of the increase in the IgG levels. Okay, and the myelin basic protein. Okay, so you will have a increase in the protein in the CSF, and you will find the oligoclonal bands. Okay, in the CSF you will get the oligoclonal banding, and there is a highly diagnostic feature of the multiple sclerosis. You will get a mononuclear cell pleocytosis. Okay, MRI is again the gold standard. On the MRI you will see these paraventricular plaques, the demyelinating plaques. Okay, and that because of a damage of the oligodendrocytes and loss of myelin. If you do the biopsy of these plaques, what you will find, every type of cell, you will find the lymphocytes, you will find the macrophages, the B lymphocyte, T lymphocyte, macrophages, antibodies. All of these will be attacking, the microglial nodules will also be seen, because you guys know whenever you have an inflammation and the proliferation of macroglial cells occur, they will form the nodules, right? So the microglial nodules will be seen on these plaques, and all these cells will be attacking the oligodendrocytes. You will get the multiple white matter lesions which are scattered in the disseminated in the space and time. What does that mean? With different episodes, patient will have a different demyelinating plaques in different areas. Like at the time of one episode, patient will have this kind of a lesion. Okay, after years later, when the patient got another episode, that demyelinating plaques will present at different location, and the patient got a different type of history, right? So, and symptoms are always kind of self-limiting, self-relapsing, right? So on the CT, you will find these oval-shaped demyelinating plaques, which are paraventricular, as you can see. On the histology, you will be having, the inflammatory infiltrates that consist of the T lymphocytes, macrophages. Myelin debris will be phagocytosed by the macrophages. You will have a foamy macrophages. Okay, paravenular B lymphocytes are also seen, which secreting the Ig antibodies. Right, axons. Please note they are spared. Only the oligodendrocytes are damaged. Right. Treatment is very much complex. Step one, don't ask you that, but you will give the patient steroids as a treatment. Okay, and the symptomatic reliefs can be given only. Okay, like for the neurogenic bladder, you can give the patient muscarinic antagonists. Right, for the spasticity, you can give the patient baclofen or the GABA. Right, for the pain, you can give the patient anticonvulsants or the TCAs. Right, so symptomatic control will be given, as well as the inflammatory control is also given, right, like the steroids. So that's about the multiple sclerosis. A young female patient having a multiple episodic history of the neurogenic symptoms, right? And it will be an upper motor neuron only, not the lower motor neuron. So always a spasticity is present, okay, not the hypotonia. Any doubt?
Could you please explain the two different findings in neurogenic bladder, because you will have had a confusing question on that.
See, at a very initial time, you will get the incontinence, okay, because of loss of micturition reflex, right? Inhibition of reflexes will be lost. So what you will get is the incontinence. You will get this urgency and the frequency, okay, like the UTI. You see, in the UTI you have the urgency and the frequency, right? Similar thing can be seen with the multiple sclerosis, but at the later stage of the disease, the overflow incontinence happen. Okay, at the very initial, urgency incontinence. At the later stages, you will have the overflow incontinence. Okay.
Okay. Yeah. Thank you.
So both type of could be there. It could be like the obstruction type symptoms when you cannot micture it at a very initial, and then you will get the overflow of the bladder. You will have a continuous dribbling of the urine, right? And especially in the night time, you will get the urination. Okay, you will have a decrease in the stream of the urine, right? So at a very initial, urgency frequency is there, and in the later stages of the disease, you will get the overflow incontinence. Okay, both kind could be there.
Okay, yeah. Thank you.
Any more doubt on multiple sclerosis? You can expect at least 2 or 3 questions from this part only. I think I got 2 questions from multiple sclerosis. I don't exactly remember, but they all have this optic neuritis in the patient most commonly. Now, any doubt?
No, thank you.
So that was the multiple sclerosis, a demyelinating syndrome. You have other demyelinating syndromes also, diseases, right? Okay, so let's discuss every of them one by one. Okay, so let's divide them with upper motor neuron lesion or the lower motor neuron lesion. Okay, in the progressive multifocal leukodystrophy, okay, and in the osmotic demyelination syndrome, you're having a demyelination of the upper motor neuron. In the acute inflammatory demyelinating polyradiculopathy, or I can say the Guillain-Barré syndrome, okay, as well as in the Charcot-Marie-Tooth disease, you're having a lower motor neuron neuropathy. Okay, so let's first discuss the osmotic demyelination syndrome, and you guys already know that it causes the demyelination of my pons, right? And as a result, you will have a locked-in syndrome. What happens is whenever the patient got, this, just give me a second. Yeah, whenever the patient has a too much of the sodium load, okay, the hypernatremia, what happens? All of this sodium will, go inside the cell, and it will bring the water along with it, right?
Yeah.
And all of the other osmolytes of the cell will be lost in order to control the osmoregulatory balance, right, inside the cell. All of these osmolytes, other osmolytes, will be lost, all proteins, right? Now, as a result, the cell will swell up because of the sodium, and that causes cellular edema. In order to correct that, when you give the patient diuretic therapy, okay, for example, the mannitol, okay, so what happens is, if you correct it too rapidly, okay, then the dehydration from the cell will occur. Okay, now because they do not contain any other osmolyte, just the sodium will be lost, water will be lost, and what you will get is the dehydration of the cell. And because of that dehydration, the demyelination will occur. Getting my point?
Yes.
At a very initial, let us suppose if this is your normal kind of a neuron, right? They will have the this influx of all the sodium. As a result, all these neurons will swell up. They will lose other osmolytes. Okay, but when you correct the sodium levels too rapidly, all of the sodium will exit the cell, and what you will get is the shrinkage of all the neurons. And as a result, because no other protein and osmolyte was present, the cell will die, and you will get a demyelination. You won't get any inflammation, please note. Okay, and you always need to differentiate it with the stroke of the pons, right? And you can do that by looking at the MRI of the patient. If you're having an inflammation, if you're having an edema, if you're having the this hypodense kind of a lesions, think about the ischemia or the stroke, right? If you're having just a demyelinating plaques, as you can see, without any inflammation, because there is no edema present, right? You call it a osmolyte, this osmotic demyelination syndrome. Okay. And if you correct, hyponatremia too rapidly, okay, you can have the edema. Okay. So when you have hypernatremia and you correct it, you can get the demyelination syndrome. Whenever you have the hyponatremia and you correct it too rapidly, you can get the edema. Okay. So on the MRI, you will see the demyelination, versus in the stroke, you will see the ischemic changes in the MRI, right? So you will get a complete paralysis of all the four limbs. Dysarthria, that means you cannot speak. Dysphagia, you cannot swallow, you cannot see properly, but you can feel everything. Horizontal gaze movement will be lost, but the vertical gaze movement will be present, right? And why is that so?
Vertical gaze is controlled by superior colliculus.
Yes, and the horizontal gaze is responsible for the cortex and other your neurons, like the third kernel and other things, right? So pons will be there. Any doubt on the osmotic demyelination syndrome?
No, thank you.
So please note, you have the upper motor neurons. Spastic paralysis will be there. When you check for the jerk reflexes, you will have the hyperreflexia, right? Not the hyperreflexia. Second, you have the progressive multifocal leukoencephalopathy. As the name suggests, it will be multifocal, just like your multiple sclerosis. Okay, it is the white matter changes. Leuko means white, encephalopathy means brain damage, right? So you have the demyelination of the CNS, just like the multiple sclerosis. You will have a multiple lesions, but unlike my multiple sclerosis, this condition is not episodic. You will have a continuous progressive changes, as the name suggests, progressive, right? So it would be a destruction of the oligodendrocytes, just like my multiple sclerosis. But unlike in case of multiple sclerosis, you do not have the episodic symptoms. You have the progressive symptoms in case of PML, right? It happens because of the immunosuppression that happens in case of any AIDS, okay, or any patient on the immunosuppressive drug therapy. It occurs because of the activation of the JC virus. So patient will have a upper motor neuron lesions, okay, focal lesions will be there. The area of the brain where the lesions are present, you will get the focal neurologic deficits there, sensory losses, hyperreflexia, and other damages like the ataxia, seizures. All of these things could be there. In the MRI, you will see the demyelinating plaques. Okay, please note, no mass effect will be there. Okay, no herniation will be there, no edema will be there. It just the white lesions will be seen. Okay, no shifting of the other structures will be there. That signifies the mass effect. If you have a mass effect, that means any edema, you will have a shifting of the other structures of the brain, right? But you don't see that changes in the PML. Okay, and yeah, that would be all about it. And why it happens? Because of the virus attacks the oligodendrocytes. Any doubt on the PML?
No, thank you.
So these are about the upper motor neuron neuropathies you will see because of demyelination. Now let's discuss the lower motor neuron damage. And the first one is the Guillain-Barré syndrome. It happens because of a cross reaction of the antibodies with the antigens present on the these Schwann cells, okay, the myelinating cells. And as a result, all of these antibodies start attacking the Schwann cells, and that causes the demyelination in the peripheral nervous system. Okay, and does anyone remember what gangliosides got damaged in Guillain-Barré syndrome? What gangliosides got damaged in Tay-Sachs disease?
GM2.
Yeah, and GM1 in the Guillain-Barré syndrome. Okay, GM2 in Tay-Sachs disease, GM1 in Guillain-Barré. Okay, so it because of the autoimmune destruction of the Schwann cells, okay, via inflammation and the demyelination of the motor fibers, sensory fibers, and the peripheral nerves, including your cranial nerve, because cranial nerve 3 to 12 are the part of your peripheral nervous system. They will be myelinated by the Schwann cells, while the cranial nerve 2 is myelinated by the oligodendrocyte, because it is nothing but just the extension of your brain, right? Okay, so it happens after a viral infection or might be a bacterial infection. For the bacteria, most common one is the Campylobacter jejuni. So it would be a patient who is having a recent history of diarrhea. Zika virus can also do that. Okay, so any patient who is having a fever, rash, arthralgias, which are general features of the Zika virus. Okay, so any fever with you're suspecting any kind of an infection, and now once the infection is over, the patient is starting having this lower motor neuropathy. And please note that this paralysis, this lower motor neuron neuropathy, starts in the lower limb first, and then it will ascend upward. That means the earliest changes will be present in the lower limbs, in the extreme portion of my lower limb, like my ankle. The loss of senses, loss of paralysis will be start in the ankle portion. It will ascend upward. Okay, within a week, it will reach up to my hip. Okay, I will have a complete paralysis of the lower limbs, complete sensory loss up to my hips. Then within next week, it will involve my ribs, okay, my thoracic cage, and as a result, I cannot aspire. I will get a shortness of breath, okay, hypercarbia I will get, and because and that's why the patient always needs the respiratory support. Okay, so please note a patient who is having a symmetrical demyelination. Okay, that means both the limbs will be involved. Okay, you will have a lower motor neuropathy in both the limbs, starting from the very distal part of your lower limbs, ascending upwards. You will get. Okay, absent of deep temporal reflexes will be there. That signifies the lower motor neuron neuropathy. Lower extremities will be affected. Facial paralysis will be happen bilaterally. Respiratory failure is also very much common, right? You will have the autonomic dysregulations like the hypertension, bradycardia. Okay, hypertension could be there, tachycardia could be there, sensory abnormalities will be there. Okay, and on the CSF, you will have an increased protein with a normal protein count because no cell is involved. It's just the antibodies which are causing this disease, right? So you will have an increased CSF protein total. Okay, but a normal cell count will be there. and you have to give the patient respiratory support until the disease is over, because it is a self-limiting condition. Steroids cannot do anything. You need to give the patient plasmapheresis, in which you remove the proteins, these antibodies, or you can give the IV immunoglobulins against these antibodies, right? But although the condition is totally self-limiting. Okay, so that would be about my Guillain-Barré syndrome. Now you guys also know that in case of my diabetes mellitus, okay, you're having this neuropathy, starting in the periphery, lower extremities, let's say, starting in the ankles and then progressively upwards, right? So how can you differentiate between the Guillain-Barré syndrome and the diabetic neuropathy?
Diabetic neuropathy will include sensory and motor both.
Same thing happening in the Guillain-Barré syndrome. We're having both the senses loss as well as the motor loss. Both diseases are ascending upwards from your ankle up to your thigh, up to your hips. So how can you differentiate if the patient is having a Guillain-Barré syndrome or the patient is having a diabetes?
Wouldn't you have to look at the patient history?
Like what history?
In Guillain-Barré, you would have a history of like a flu or a diarrheal sickness.
Okay, just by looking at the symptoms, what you can say? Just by looking at the symptoms. I mean, if the someone don't mention such kind of history, if it was just a patient who is in the hospital and suddenly started having this, the loss of all the senses and these
Guillain-Barré would
these
be
motors, Guillain-Barré would be
faster?
exactly. Guillain-Barré will be faster. Within a week, you have the demyelination involving complete your lower limb. But in my diabetes, it takes around a year to develop, right? You started having this peripheral neuropathy in the ankles, then up, after like certain years later or months later, you will get the loss of all the senses and the motor controls up to my hip level, right?
Okay.
Yes.
The symptoms are very important. Duration of the symptoms are very important. Okay, faster in case of Guillain-Barré, is slower in case of my diabetes, but the symptoms exactly similar in both the conditions. Any doubt in the Guillain-Barré syndrome?
No, thank you.
Okay. Then you have the Charcot-Marie-Tooth disease. Okay, and it is a hereditary condition. Okay, having a peripheral neuropathy because of a peripheral demyelination. It happens because of a defective production of the myelin. Okay, Schwann cells become defective. They start secreting defective kind of a myelin, and as a result, the demyelination will occur in the periphery. This condition is hereditary. It can affect both the adults as well as my teenage. Symptoms are kind of similar to that of my Friedreich's ataxia. And does anyone know the symptoms of my Friedreich's ataxia?
Cardiomyopathy, diabetes mellitus, ataxia.
In terms, not the complications, but the symptoms.
Ataxia, pes cavus,
Exactly, you will have a pes cavus. And what does a pes cavus means?
arching of the foot.
Exactly, you have the increased arches of the foot. You will be having a hammertoe. You will have a foot deformities like that, right? Foot drop will be there just like with Friedreich's. So symptoms are kind of very much similar to that of Friedreich's ataxia. But please note that the Friedreich's ataxia is an upper motor neuron damage, while the Charcot-Marie-Tooth disease is a lower motor neuron damage. So you get a hypotonia in case of Charcot-Marie-Tooth disease, and you get a spasticity or hyperreflexia in case of Friedreich's ataxia. Is that okay?
Yes.
Rest all the symptoms, the paralysis, foot drop, sensory loss, everything will be similar in both the cases. It just you look for the upper motor neuron or the lower motor neuron side. Okay, it happens because of a defect in the CMT1A. Okay, that happens because of a PMP22 gene mutation. It is Charcot-Marie-Tooth disease 1A gene. Okay, and yeah, that's all about it. Okay, these genes you must remember, PMP22 and the CMT1A. Okay, you have the peripheral demyelination, and as a result, you will get the high arching of the foot. Hammertoe will be there, right? Foot drop, sensory losses, just like any other lower motor neuron damage you will get. Okay, and you will also get the muscular atrophy in both. Sorry, you won't get in a case of Guillain-Barré syndrome because it is a very short duration of the symptoms, but you can get a muscular atrophy in case of the Charcot-Marie-Tooth disease. Okay, which you won't see in case of Mephitis ataxia. Okay, so these are again a differentiating feature between the Charcot-Marie-Tooth disease and the muscular and Mephitis ataxia. Okay, any doubts
Yeah.
so far?
No, thank you.
Now, again, you have the acute disseminated encephalomyelitis. Again, upper motor neuron signs will be seen. And this condition generally seen after a viral infection. If you have a lower motor neuron signs after a viral infection, think about the Guillain-Barré. If you're having upper motor neuron signs after a viral infection, think about the acute disseminated encephalomyelitis. You will have a multiple demyelinating lesions, just like in case of multiple sclerosis, just like in case of PML, okay, within 3 months of the viral illness. Nothing but just the focal neurology deficits will be there. Altered mental status will be there. On the MRI, you have these multiple demyelinating plaques, and the symptoms are generally self-resolving. Okay, and yeah, it can be happen after a viral infection, or it can be happen after the vaccination. Any doubt so far on these diseases?
No, thank you.
Okay. And whenever you have a distal weakness more than the proximal weakness, step 1 will mention you this high stepping gait. Okay, in the Guillain-Barré syndrome, you can have this high stepping gait. Okay, because the lower, the distal weakness is always more profound than the proximal weakness, right? In case of Guillain-Barré syndrome, so you can also have the high stepping gait. Okay, know that also. Other demyelinating disease, first one is the Krabbe's disease. And does anyone remember what enzyme become defective in case of my Krabbe's disease?
Cerebroside is no
What
galactocerebrosidase.
exactly? Galactocerebrosidase, right? It will become deficient, and as a result, I will have accumulation of my galactocerebrosides. Metachromatic leukodystrophy. Anyone remember?
Sulfatide accumulation.
Exactly. You have a sulfatides accumulation because of a sulfatidase deficiency, right? Adrenoleukodystrophy. Does it a lysosomal storage disorder?
It's a peroxisome disorder.
Exactly. It is a peroxisomes disorder, right? So these are the other things you will get the demyelination of the CNS. Okay. And yeah, that would be all on this page. Any doubt? Please ask.
No,
No,
thank
sir.
you.
Now you have the neurocutaneous disorder, and as the name suggests, all of them have the neurological symptoms as well as the skin symptoms. Okay. The first one is the Sturge-Weber syndrome, and there is no easy way to learn them. You need to keep memorize them again and again. Then only you will get the the detail of every of these diseases. Okay, so no easy way. First is the Sturge-Weber syndrome. Okay, it basically happens because of a defect in the neural crust cells. First thing, it is a GNAQ mutation. And does anyone remember what other mutations I can get? What other syndromes I can get because of this kind of a mutation?
McCune-Albright or the pseudoparahypothyroidism.
Yeah, exactly. Very good. Okay, you will get the McArdle syndrome because of that, and the pseudo-hyperparathyroidism, right? Because of this thing. And please note, it is again a mosaicism, just like my McArdle disease. It is also an example of my somatic mosaicism. Okay, it happens because of the activating mutation in the GS or the GNAQ gene, which is coding for the GS protein. Okay, and happens in the neural crust derivatives. Okay, you will have a capillary malformation. You will get the AV fistulas in my face, and as a result, the blood will be flowing very much, with a very slow speed in my face, and as a result, you will get something known as the port wine stain. As you can see, the blood is very slowly moving in this area, and that's why it will appear very red, and you call it a port wine stain. Unilaterally, it will be present, right? You will have the involvement of the cranial nerve 5-1 and 5-2. That means the ophthalmic and the maxillary division of the trigeminal nerve. The distribution of this stain or this pigment will be present in this fifth and the second nerve, right? You will have the ipsilateral leptomeningeal angioma. Okay, and what does this leptomeninges means?
Paya and arachnoid.
Pia and the arachnoid matter. You will have an angioma involving the pia and the arachnoid matter, and because of that, because a lesion is present in your brain, you can have the seizures, you can have the epilepsy, right? Intellectual disability will be present. Okay, and you will get the episcleral hemangioma, and because of this episcleral hemangioma, which is involving your eye, patient can get the increase in the intraoptic pressure. The patient will get the glaucoma, and it is on the same side. So a patient who is having some kind of a unilateral stain on their face, okay, seizures and glaucoma. Think about the Sturge-Weber syndrome. Okay, three things only: stain, epilepsy, and glaucoma. And please note, it is on the same side of the stain. If you do the MRI, you can find these lesions presenting on the same side of the stain of the patient, right? Okay, so that's about the Sturge-Weber syndrome, GNAQ mutations, GS activating type, neurotransmitter cells, mosaicism. Okay, and these three features you will get. Then you have the tuberous sclerosis. It is a all of these conditions except the Sturge-Weber syndrome. These all are autosomal dominant. So you just don't remember. It is kind of obvious that they are autosomal dominant. Okay, you're having a mutation in the tumor suppressor gene TSC1 and the TSC2. TSC1 codes for the hamartin and TSC2 codes for the tuberin. You need to remember the protein names. You don't need to remember the chromosomal number, but you must remember the protein name. TSC1 codes for the hamartin, TSC2 codes for the tuberin. Okay. Now, you will have the high activity of mTOR. Okay. And does anyone remember the mTOR? Full form of mTOR? No one?
Is it a signaling pathway?
Mammalian
Yeah.
target
Mammalian target.
of rapamycin.
Yeah, mammalian target of rapamycin. Okay, when the interleukin-2 binds on its receptor, the signals of the interleukin-2 will be transmitted by the mTOR, right? Don't forget that. So what symptoms you will get? First, you will get these, the hamartomatous lesions on the skin. Okay, as well as on the brain also you will get the hamartomas in multiple areas of your body, right? You will have the angiofibromas. Okay, and these are some kind of papules which are found in a butterfly distribution on your cheeks and on your nose, just like the malar rest. Remember,
Yes.
like the malar rest, these are the papules which are found on your cheeks and the nose. As you can see, these papules are found on the cheeks and the nose of the patient. Okay. Now, another thing, you will have the middle regurgitation. You will have the ash leaf spot. Okay, as you can see, this is the hypopigmented leaf-like spot you will see, and you call it a ash leaf spot, hypopigmented lesion. Please remember, you have the rhabdomyoma. Okay, and if you know the symptoms of the rhabdomyoma,
Is it like a functional mitral stenosis?
yeah, you will get a mitral stenosis or maybe the aortic stenosis also, right? In case of rhabdomyoma. Okay, you will have the tuberous sclerosis, of course. You have the autosomal dominant condition. It has the mental retardation also. Any of the condition can have the mental retardation, of course, right? You also have one important thing, and that is the most important part. You have the angiomyolipoma. As the name suggests, it consists of three parts. One is the angio, that means the blood vessels, myo, that means the muscles, and lipoma, that means a fat tumor. And this kind of a tumor is present in the kidney, and because it is taking the space of the kidney, it will affect the function of your the nephrons. It will cause the chronic kidney failure. Patient will have a high creatine count. They have this oliguria and the kidney failure. Okay, they have a very large mass on the kidney, and when you do the biopsy of that mass, you will see the blood vessels, you will see the fat, you will see the muscles in that mass, and that's how you know patient is having a angiomyolipoma. So hamartomas of the skin and the CNS, and because of this hamartomas, Patient can also again get the seizures, just like your, the Sturge-Weber syndrome. Okay, you will also have the hamartomas of the skin. So remember hamartomas. Okay, you will have the angiofibromas, angiomyolipomas, rhabdomyomas. Okay, these four things are important. Okay, TSC1, TSC2. And please note, you also have an increased incident of the subependymal giant-cell astrocytoma. And because it is subependymal, it will cause the obstruction of your CSF flow. It can cause the hydrocephalus. And what age group can have the tuberous sclerosis?
Children.
Would it be a very old age? Yeah, it would be a children. Okay, and a children with the hydrocephalus, with some kind of a papules on the skin, with seizures, intellectual disability, sometimes aortic stenosis. Okay, and a hypopigmented rash, leaf-like rash. Think about the tuberous sclerosis. Okay, any doubt on the tuberous sclerosis?
No, thank you.
Okay, then you have the neurofibromatosis type 1 and the neurofibromatosis type 2. Okay, both conditions are autosomal dominant. In the NF1, you have an NF1 tumor suppressor gene mutation, okay, that codes for the neurofibromin, okay. In the NF2, you have an NF2 tumor suppressor gene mutation, which codes for the Merlin, okay. In the NF1, you can have a caffeolate spots, okay. It look like, someone thrown a coffee at you. As you can see, these are the hyperpigmented spots, hypopigmented in the tuberous sclerosis, hyperpigmented in the neurofibromatosis. And does anyone remember, spots like these can also find in one more condition? No one?
Men one?
No, not the men one. The mosaicism example.
In McCune-Albright?
Exactly. McCune-Albright syndrome, you will get the same kind of a spot unilaterally, and it would be a very large spot covering the unilateral surface of your face or your trunk. Okay, so do remember the symptoms. Okay, so the first is the caffeolate spot. You will get intellectual disability, just like with any other condition. You will get the cutaneous neurofibromas, which are the Schwann cells tumor, and the Schwann cells which are myelinating your sensory nerves, the cutaneous nerves, right? The neurofibromas will be found there, and it will appear on the skin as these kind of a pedunculated lesions. You will see, these kind of a pedunculated masses will be seen, and these are the cutaneous nerve cell tumors of the Schwann cells. These are the cutaneous neurofibromas. You will get the Lish nodules, and it is nothing but just a hamartoma in the eye. As you can see, these are the hamartomatous lesions you will see in the eye. You call it a Lish nodule. Okay, you got an optic glioma because of that, a complication. You will get the pheochromocytoma. And does anyone remember the other mutations can cause a pheochromocytoma?
Right.
Okay, and one apple in down.
Yeah.
One apple in down, NF1 red, or you can say the MAN2A 2B. They can cause the pheochromocytomas. Okay, please remember the mutations. You will again get the seizures just like with any other disorder, so not so much important. Okay, you will get the focal neurologic signs, of course, because of the meningioma. Okay, you will also sometimes get the bone lesions. Okay, nothing much very important. Just know patient will get a very hyperpigmented rash along with some cutaneous flashy tumors, pedunculated masses, Lish nodules or the iris hamartoma will be seen. Okay, and these three features are very important: caffeolate spots, cutaneous neurofibromas, and the Lish nodules. These three things will help you determining the neurofibromatosis, diagnosing the neurofibromatosis. And does anyone ever encounter a case of NF1 in the clinical rotations?
No.
No.
We have one time got a case of this NF1 in the ophthalmology department. It was so kind of a rare and so amazing. Okay, so yeah, that's how I remember all these examples. Once you saw the patient, you won't forget their kind of history represent you. Okay, So it is also known as a von Rettesculam disease. Okay. Yeah, that would be all about it. And please note, it has the 100% penetrance. And any other disease which has the 100% penetrance?
Huntington's and
Huntington, and one more.
Colon
Con-
cancer.
Familial.
Colon cancer. Any other?
Familial.
achondroplasia.
Achondroplasia, exactly. Achondroplasia is an important one. Okay. So colon cancer can be, you can say, right? Where were we? Yeah, achondroplasia, NF1, and Huntington are the three major examples you must remember for the 100% penetrance. Okay. If you have the mutation, you will get the tumor for sure. Okay. And yeah, that would be all about the NF1. So any doubt?
No, thank you.
Okay. So now I have the NF2. Okay, Jay, I just have to remember you will get a bilateral vestibular schwannomas. Okay, and you will get the a sensory vertigo. You will get, okay. You will get this nystagmus kind of a thing. It will also affect your facial nerve. This tumor can affect your facial nerve. You will get the loss of facial nerve. Symptoms like the Bell's palsy will be there, right? So vertigo, nystagmus, along with the facial palsy will be the symptoms for the bilateral vestibular schwannomas. So you will get a juvenile cataracts, meningiomas, and the ependiomas. Okay, so this kind of a history will present. So a patient who is having a cataract and the bilateral schwannomas, think about the NF2. If it is a unilateral schwannoma, it could be sporadic. If it is bilateral, it must be associated with the NF2. Okay. Then you have the von Hippel-Lindau, which is a mutation in the 3p short arm of the third chromosome. Okay, and please note it codes for a inhibitor of the hypoxia inducible factor 1a. That means it inhibits my hypoxia inducible factor, and as a result, the angiogenesis will be inhibited. If the tumor is not there, the cells, the angiogenesis will happen, and patient will get the hemangioblastoma. Okay, and all of these tumors are highly vascularized tumors. When you do the biopsy, you can see the dilated blood vessels in all of these tumors. Like in case of hemangioblastoma, you will see the dilated blood vessels. Okay, especially in retina, you will get the hemangioblastoma. Okay, other areas include the brain, cerebellum, spine. Okay, angiomatosis will be there. Okay, you will have the renal cell carcinoma and you will have the pheochromocytoma, and all of these tumors, they will release one hormone. Does anyone remember?
Polycythemia, EPO.
Yeah. EPO, exactly. All of these tumors have a capability to release the erythropoietin. So in all of these conditions, you will get the hypertension and the hyperviscosity. Okay, because of hemangioblastoma. If they're present in the cerebellum, patient can have a history of ataxia, okay, and the fall on the one side, right? If they're present in the retina, patient can have a history of vision loss. In the brainstem, they can also be there, as you can see. In the brainstem and in the spine, they can be found. So again, the neurological symptoms will be there. In the RCC, you will get the episodic hypertension, headache, blurring of the vision. Sorry, in the phacocytoma. In the RCC, it is generally clinically very much silent. You will get, some flank pain sometimes, and the symptoms generally there whenever the metastasis happen, right? Shortness of breath and bone pain, uh, and it is all because of the metastasis, right? So these are all the things you will see in the von Hippel-Lindau. Now, any doubt on this page?
No, thank you.
So you have to remember, you have to keep memorizing these disorders again and again. Then only you will remember them. Okay. Just remember the key features of every of disease, because like the intellectual disability, seizures are very much common with every of the disease. So you can forget that. Okay. So just remember the basic, and a very specific features. Like in case of stress Weber, you'll get this port wine stain, as well as the this glaucoma. In a tuberous sclerosis, you will get the angiofibromas, as well as the angiomyolipoma, right? As well as the hypopigmented lesion. Hyperpigmented lesion with the cutaneous fleshy tumors, and the iris nodules will be seen in neurofibromatosis. In the type 2, you will get the cataracts, along with the schwannoma and the von Hippel-Lindau, you will get the triad of hemangioblastoma, RCC, and PCC. Okay. An easy way to remember all of these names. Okay, then you have the brain tumors. Okay, we will discuss the adult brain tumors and then the brain tumors of the children, right? In the adults, you can have 5-6 tumors. 4 are listed here. These are the glioblastoma multiforme, oligodendroma, meningioma, hemangioblastoma. So you have different cells in the brain, okay? And tumor can be originate from any of the cell. If you have a tumor of the astrocytes, which are supporting cells of your brain, you will call it a glioblastoma multiforme. If you have a tumor which is in the cell myelinating your CNS, that means oligodendrocytes, you can have the oligodendrioma. If you have a tumor of the leptomeninges, you can call it a meningioma. If you have a tumor involving the blood vessels, you call it a hemangioblastoma. Okay, all of these tumors are present on the above the tentorium cerebelli. That means all of them are present above the level of my cerebellum, except the hemangioblastoma. This is the only tumor which is present in the cerebellum. Rest all tumors are present above the level of my cerebellum. Okay, so let's first discuss the glioblastoma multiforme. It can happen anywhere along your CNS. Symptoms will be again the focal neurologic deficits you will get because this tumor will be taking your brain space. Okay, seizures are the most common presenting complaint. Okay, so focal neurologic deficits, headache, seizures, that's the symptom you will get. Okay, and whenever you diagnose this carcinoma, this tumor, it will be very late. Okay, and when you got a grade for astrocytoma, okay, because this tumor is highly malignant, you will only get a 1-year survival. Okay, after 1 year, the patient will die. Okay, these are found in the cerebral hemispheres. It can cross the corpus callosum, so it will become bilateral. It will be a bilateral tumor. You don't need to remember the butterfly glioma. You will never see some kind of a structure. Just know a ring enhancing mass, as you can see, a ring enhancing lesion will be present. Okay, and please note that it is a highly hemorrhagic tumor. So when the patient die, okay, and you do the autopsy of the brain, what you will see a hemorrhagic mass, okay, a necrotic mass in the brain of the patient, and that necrotic and hemorrhagic mass will let you do a diagnosis of the glioblastoma multiforme. Is that okay?
Yes.
So on the cross finding, a hemorrhagic necrotic mass will be seen. Okay, and please note you will have a GFAP mutations. GFAP positive will be there. Astrocytic origin. On the biopsy, if you take when the patient died, because this biopsy can only be performed when the patient died, right? Once you do the biopsy, what you can see again the necrosis, because it is a necrotic mass and it is a hemorrhagic mass. You will see a lot of blood vessels there, necrosis, and because of this necrosis, you will have a pseudo palisading. All these cells will arrange themselves, their nucleus perpendicular to the necrosis, as you can see. Along the circumference of my necrosis, you will get this pseudo palisading. You will also get the dilation of the blood vessels. It is not shown in this histology. Okay, so a new vessel formation, necrosis, pseudo palisading, that will be seen on the histology or the microscopy of the patient or the biopsy of the lesion. On the gross finding, what you will see are the necrotic hemorrhagic mass. Symptoms will be the focal neurologic deficits, seizures because it is a brain lesion, right? And you will also get the headache because of that. So that's about my glioblastoma multiforme. Any doubt?
No, thank you.
And please note, you will also get a mutation in the platelet-derived growth factor. Okay, you can also get the GFAP because, you can get a this glioblastoma multiforme because of my PTGF mutations. Then you have the oligodendroma cells, which are myelinating your central nervous system. And because of that, you will get a demyelinating like a plaque. As you can see, this kind of a enhancing mass, not a ring enhancing, but a normal enhancing mass will be seen in the medulla of the brain, not the cortex, but the medulla, because the oligodendrocytes are present only in the medulla, not the cortex, right? In the white matter. Okay, it is most commonly seen in the frontal lobes. So the symptoms will be the paralysis, behavioral changes will be there in the patient, right? Broca's area, if it is affected, it can cause this aphasia type of thing. So depending upon the location of the tumor, you can get a focal neurologic deficits. Again, you will get the seizures, you will get the headache, just like with any other tumor. Okay, symptoms are kind of very much same. And whenever you encounter a patient with the seizures, the first thing you have to perform is the MRI to make sure that the patient is not having any kind of a tumor or a necrotic mass, right? So once you perform the MRI or the CT, what you will find this kind of a enhancing mass, and that's how you know that the patient is having might be the oligodendryoma. Okay, because this tumor is always calcified, it will be seen as the enhancing mass because of the calcification. Okay, very important. And um, yeah, so on the biopsy, and once the patient die and you perform the biopsy, what you will see are the these fried egg cells. Okay, and does anyone remember why these fried egg cells?
Because the nucleus is comparatively larger, relatively
Okay, you will
larger.
have a very large nucleus and a very less cytoplasm, as you can see. A very large nucleus and a very less cytoplasm, a clear cytoplasm, I must say. Okay, a clear cytoplasm will be present and a very large. This is a complete cell, as you can see. This is a complete cell. The nucleus is very big as compared to the cell, right? So that kind of appearance you will see because these are the hallmark feature of oligodendrocytes normally, right? So the fried egg cells will be seen on the histology. And on the gross finding, what you will find is the very calcified tumor mass. A calcified tumor you will see on the gross. You will immediately know that the patient is having a oligodendryoma, right? So the patient will be presented with the focal neural deficits, seizures, or might be the headache. You will perform the MRI. You know that it is a calcified mass. Patient is having the oligodendryoma. When the patient died, you will perform the cross findings. Cross finding will show you the calcified mass. You perform the biopsy. On the biopsy, you will see the fried egg appearance. Any doubt?
No, thank you.
Oh, thank you.
Now you have the meningioma, okay, and this especially arises from the arachnoid matter. Okay, it is classically seen in the females more than the males. Okay, it occurs near the parasagittal sinus, okay, which is present between the two cerebral hemispheres. So this tumor is mostly in the midline, and because this tumor is in the midline, okay, and if you guys remember the homunculus, the first focal neurologic deficit patient can have is the lower limb paralysis and the sensory loss, right?
Yes.
Because of the location of this tumor, you will get the lower limb paralysis or the sensory loss. Okay, and please note that this tumor is a highly well circumscribed tumor. Its border are highly circumscribed. Okay, if you do the gross finding of the patient once the patient died, what you will see a very kind of a ball-like mass. It has a very well circumscribed borders. You can easily differentiate it with the other structures of the brain. It is a highly vascular, a highly demarcated and a bordered mass like a ball you will see, which is attached to the meninges. And because it is attached to the meninges, you can find these kind of a tails, the attachment point on the meninges. These kind of a tails will be seen. Okay, and the cortex part will be affected, as you can see, and wherever this tumor is present, you will have the focal neurologic deficits according to that. Okay, if this patient uh, if this tumor is present near the parasagittal sinus, in the right parasagittal sinus, patient can have a hemineglect. In the left sided, it can lead to the Gerstmann syndrome, right? So depending upon the site, you can have the focal deficits. Seizures, headaches are other signs and symptoms. Okay, just like with any other tumor, you will get it. Okay, and once the patient die, you will check the cross finding. It will be a ball-like mass. You will do the biopsy. In the biopsy, you will find the samoma bodies, very important, which are the calcified masses within the tumor. You will see, at these kind of a circular concentric ring-like deposition of the calcium you will see on the biopsy. So this is the samoma bodies you will see. Okay, and please note these are the spindle shaped cells. Spindle shaped cells are nothing but a classical term for these stromal cells. Okay, these kind of they have this elongated nuclei like thing, as you can see. So these are all the stromal cells which have the elongated nuclei, and these are present in the word-like pattern. Just like the smooth muscle tumor, you have the word-like pattern. Similar pattern will be seen in the meningiomas, these word-like patterns, right? So that's about the meningioma. Any doubt?
No, thank you.
And finally, you have the hemangioblastoma, and this is the only tumor which affects the cerebellum. Rest all tumors affect the cortex, the cerebrum. right? So it is a tumor of the cerebellum. So you have the ataxia, you have the gait abnormalities. Wide base gait could be there depending upon the location. If it is more centrally, you can get an involvement of the vermis. Patient can have a wide base gait. If the tumor is more laterally, it can affect the cerebral hemispheres. Okay. And does anyone know if this is the right side or the left side?
Right side.
Right side.
Yeah, because you're looking for the left from the leg of the patient, right? So this is the right side, this is the left side. So if you're having a lesion in this side of the cerebellum, what symptoms you can expect?
All on the left side.
Right side, ipsilateral side always, right?
Okay, yeah.
So patient will have a fall on the ipsilateral side, right side. Dysarthria would be there, dysmetria, sorry, not a dysarthria, dysmetria, diatokinesia, intention tremors, right? All of these symptoms will be there in the patient. Okay, you will do the MRI, you will find this type of a mass, and once the patient dies, okay, and you do the biopsy, it is a hemorrhagic mass, not a necrotic, but only a hemorrhagic. Both necrotic and hemorrhagic mass is there. It will be a glioblastoma multiforme. If just a hemorrhagic mass is there, it will be the hemangioblastoma. You will see the dilated blood vessels, as you can see. This is a blood vessel, and it is filled with the blood, right? RBCs, as you can see. All of these are red things. These are the RBCs and the blood. So the dilated blood vessels will be seen on the biopsy of the patient. On the MRI, you have two components. Okay, one is the solid component, and second is the cystic component. The solid component will be appear as this enhancing mass, enhancing nodule, and the cystic component will have the edema surrounding this tumor. Actually, you can have edema in any of the tumor. Mostly in case of glioblastoma multiforme, you have the edema. And does anyone know if this is a vasogenic tumor? A vasogenic edema or a cytotoxic edema?
Vasogenic.
Yeah, it is mostly a vasogenic edema you will get in both the condition, and especially in case of hemangioblastoma, because you're having a blood vessel tumor, the blood vessels will be leaky, the blood will leak, okay, all this fluid will leak, and it will cause the edema, as you can see, the hypopigmented or darkened area surrounding this enhanced nodule. This is a cystic component, okay. So that's about all these blood tumors. You remember the MRI, remember the gross findings, remember the biopsy. Symptoms are almost same for any other tumor. Okay, so the only thing that you must remember is the biopsy and the MRI of the and the gross finding, right? And they will give you the MRI sometimes, and they will ask you what symptoms patient can have. So looking at the MRI, you first need to calculate, that what area is involved, and then you can go for the symptoms, right? So these kind of questions can be framed on these tumors. Please note, these are all the primary brain tumors, and these primary brain tumors, they have generally a solo lesion. In case of a metastasis, because mostly in the brain, metastasis happen by the hematogenous route, right?
Yeah.
And because multiple arteries are present, these tumor cells can go in any of the artery, and even they involve the multiple arteries, right? So whenever you have a secondary brain tumor, it will always be multiple brain lesions, not a single brain lesion, but a multiple brain lesion will be seen. The most common presenting complaint is the seizures and the headache. Okay, you will see, the most common sites from where the tumors metastasize. These are the lungs and the breast and the kidneys, and the tumor location are at the gray white matter junction. So multiple brain lesions, gray white matter junction, okay, and seizures, and again all these things are present in the secondary brain tumor. But see, this is just a most common presenting complaint. It is not always true. Patient can also get a a solo mass in the metastatic tumors, especially NBM. We love that they will always give you some atypical kind of a history, right? So please note, multiple masses or single mass can also be there in case of metastasis. I remember NBM mentioned only a single mass, not a multiple masses whenever they want to give you this secondary brain tumor. So yeah, please remember that also, right? Metastasis can happen from any of the tumor. You have the optic glioma, which is seen in the neurofibromatosis. It affects the optic nerve. It is a tumor of the immature astrocytes. Patient can have the horizontal fibers. We will discuss them later, don't worry. Okay, but just know it is a tumor of immature astrocytes, just like a tumor in the children, the immature astrocyte tumor in the children. Okay, it is same as that of it, optic glioma, seen in the neurofibromatosis type 1. Okay, now any doubt on this page, please ask.
No, thank you.
No, thank you.
Then you have the pituitary adenoma. We have discussed it many times. Okay, the most common one is your prolactinoma. Then comes your growth hormone tumor. Then comes the ACTH secreting tumor. It could be a functional tumor. It could be a non-functional tumor. If it is a functional tumor, you will have a symptoms of the hyperpituitism. Okay, along with the symptoms of hypopituitism of other areas. If it is a non-functional tumor, you will have a history of hyperpituitism. Patient will have a headache, and especially because the pituitary is just present above the optic chiasm, patient can have something known as bitemporal hemianopsia or bitemporal hemianopia, right? Because of the compression of the optic nerve. So whenever you encounter a patient having the headache as well as the bitemporal hemianopia, always think about the pituitary adenoma. Patient cannot see the peripheral visions bilaterally. They can only see this middle vision, right? We will discuss that later when we discuss the ophthalmology. So don't worry about that, what the bitemporal hemianopia is. Just remember, you will get this condition in case of pituitary adenoma. Okay, because you have this new vascularization in this tumor. Okay, these blood vessels will become very leaky. They will cause the hemorrhage, hemorrhage there, right? You can have something known as a pituitary apoplexy because of that. Okay, because of the hemorrhage, right? And because of the prolactinoma, patient can have the galactorrhea, amenorrhea, bone density will be decreased, osteoporosis, decreased libido, infertility. All of these things are present in the pituitary adenoma, right? Depending upon what kind of a tumor it was. Treatment for the prolactinoma includes the dopamine agonists like the bromocriptine and the cabergoline because they inhibit the prolactin secreting cells, right? Or you can do the resection of the tumor also, right? And yeah, it is the hyperplasia of one type of endocrine cell in the pituitary. Most common type is the prolactin tumor secreting, right? So that's about the pituitary adenoma. Nothing much different. We have discussed everything in the endocrine section, right?
Yes.
So any doubt on the pituitary adenoma?
No, thank you.
And finally, you have the schwannoma, which is a tumor of the Schwann cells. That means the peripheral nerves. Okay. Although it can affect any of the peripheral nerves, the most common one is the eighth nerve, the vestibulocochlear nerve. And this tumor generally seen at the cerebellopontine angle, which is in this part, as you can see. Okay. And yeah, so, and please note that the eighth nerve and the seventh nerve lie very close to each other. So because this tumor is affecting the eighth nerve, compression of seventh nerve can also happen, and patient can get the symptoms of Bell's palsy, dropping of the corner of the mouth, unable to close the eyes. You will get, right, loss of lacrimation, loss of tearing, right, loss of taste senses. All of these things will also be present. Along with that, you will have the ringing in the ear, you will have the vertigo, you will have the nystagmus because of the eighth nerve involvement. And it is, it is a progressive type of vertigo nystagmus, because you see episodic nystagmus, episodic vertigo also, like the Meniere's disease. So you have to differentiate the conditions. In case of the schwannoma, you will be having a progressive symptoms. Okay, bilateral vestibular schwannomas is found in the neurofibromatosis type 2. You will have this lesion as well as similar lesion on this side, right? Once you do the biopsy of the patient, you will see two areas. Okay, the Antony A and the Antony B areas. Antony A is the hypercellular areas. You will see lots of cell there. In the Antony B, you will have a hypocellular areas. And this Antony A, they sometimes form the palisading masses, as you can see. This is the hypercellular area you will look for. Okay, in the Antony A, you can find this kind of a palisading masses opposite to each other. Okay, this kind of a thing will be seen opposite to each other, and you call that a varicose bodies. Okay, that you will find on the schwannoma. Okay, and it is also a word-like masses, as you can see. Okay, as you can see, all this palisading will be seen in the Antony A. This is the Antony A. They haven't shown the Antony B here. Okay, so these kind of a palisading masses, and this, if I zoom, just give me a second. Yeah. This is a varicose body. Okay, the parallel palisading masses. Any doubts so far on the schwannoma?
No, thank you.
Thank you.
And because the Schwann cells are derived from the neuronuclear cells, these tumors, just like the melanoma, they also have the S100 positive. Okay, it is a biphasic tumor. We have discussed hypercellular as well as hypocellular. Both areas are present. Spindle cells are seen, which are the elongated type of cells, right? You have the tinnitus, vertigo, nystagmus, unilateral or could be bilateral depending upon the cause. You will also have the seventh nerve compression along with fifth nerve or sixth, sometimes, right? Fifth nerve mainly. Okay, so symptoms could be there. You also call it the acoustic neuroma. Okay, same thing. Okay, that would be all on this page. Any doubt, please ask.
No, thank you.
No, thank you.
So that's all about the adult primary brain tumors. Now you have the childhood primary brain tumors. Okay, just like the adult tumors, the tumors of the astrocytes and the meninges. Okay, and then the other cells. You have the similar tumors here. Okay, the tumor of the astrocytes in case of child, it is called as the pilocytic astrocytoma. Okay, the tumor of the immature kind of cells, okay, the neuroectodermal cells are known as the medulloblastoma. And if you guys remember, go back to the endocrine, we have discussed, one pattern, the homerite rosettes, right? In what
Yeah.
tumor?
Neuroblastoma.
In the neuroblastoma, right?
Neuroblastoma,
So
yes.
only two tumors, the neuroblastoma and the medulloblastoma, they have the homerite rosettes, right? Then you have the tumors of the ependymal cells lining your ventricles, you call it ependyoma. You have the craniopharyngioma, which is a tumor of the pituitary, not the pituitary, but the Rathke's pouch actually. You have the pineal gland tumor known as the pinealoma. So let's discuss all these tumors one by one. So first you have the pilocytic astrocytoma, which is a tumor of the immature astrocytes. Okay. And just like with any other tumor, you will get the seizures, patient will get the seizures, patient will get the headache, focal neurologic deficits will be there, right? And it is a most common type of primary brain tumor. It is generally, and yeah, all of the childhood tumors, they found in the posterior fossa below the tentorium cerebelli. What I mean that all of these tumors, they involves the cerebellum. Unlike the adults, all of the tumors involving the cerebrum, these all tumors involving the cerebellum. Okay, so it is a tumor in the cerebellum. You will get the ataxia. Okay, because of that. Okay, and sometimes the cerebral aqueduct can be compressed. Patient will get the hydrocephalus also, right? Bulging fontanelle and all this increased head circumference, headache, seizures, focal neurologic deficits. All things will be there in the pilocytic astrocytoma. How you can identify this tumor is important. Once you do the MRI of the patient, just like the hemangioblastoma in my adult, you will find two components. One is the solid and second is the cystic, because this tumor also has the vasogenic edema, because it is again a necrotic hemorrhagic mass. You will get the vasogenic edema and that causes the cystic component, and you have the solid tumor itself, right? So two components are present. Once you do the biopsy of the patient, you will find these kind of a corkscrew-like masses. Okay, these kind of a corkscrew-like masses will be seen everywhere, as you can see, right? And you call it a Rosenthal fibers. And these are the eosinophilic corkscrew masses on the biopsy. On the gross finding, you have the cystic mass as well as the solid component, right? So that's about the pilocytic astrocytoma. You will encounter a patient having an ataxia, having headache, hydrocephalus, seizures, right? You take them for the MRI, you will find this solid cystic component, right? Once the patient die, you will do the biopsy, you will find these corkscrew-like appearances. Okay, so any doubt on a pilocytic astrocytoma?
No, thank you.
Second, you have the medulloblastoma, which is a tumor of the primary neuroectodermal cells. And these are the immature cells. Okay, that's why the name blast. Okay, and this is a most common malignant tumor. Okay, the most common primary brain tumor of the childhood is the pilocytic astrocytoma. The most common malignant tumor in the childhood is the medulloblastoma. Okay, it generally involves the cerebellum and can compress the fourth ventricle, just like my pilocytic astrocytoma. Symptoms are exactly similar: ataxia, hydrocephalus, seizures, headache. Right, all of these symptoms are same: papilledema, tracheal ataxia. Right, And once you do the MRI of the patient, what you will find only the solid component, no cystic component, just the solid component will be there in the MRI. And once you do the biopsy of the patient, you will see this eosinophilic mass in the center. Okay. And surrounding this mass, you have this kind of a primitive neuroectodermal cells, which are appearing just like the lymphocytes, right? These cells are appearing just like the lymphocytes. Okay, so small round blue cells will be surround this eosinophilic center. And this kind of a feature is known as the Homer-Wright rosettes. Same thing will be seen in the what condition again? What tumor?
Neuroblastoma.
Neuroblastoma. Same thing could be seen in the neuroblastoma also. Small round blue cells, and these are these neuroectodermal cells surrounding a eosinophilic center. Okay, and in this eosinophilic center, you can have the neutrophils also, as you can see. These are the neutrophils, right? Yeah, I have found this one. Looking at this cell, I hope you guys can appreciate that. Let me draw that. Yeah, this is a neutrophil, right?
Yes.
So all these cells will be surrounding the neutrophils or the eosinophilic center, whatever you want to say, right?
Yeah.
Okay, so that's about the medulloblastoma. Symptoms are exactly similar. It's just a biopsy, MRI. Okay, that will help you determining the type of this the tumor, right? And this tumor can also show the drop metastasis. It can reach to the spinal cord by dropping. Okay, small masses of the tumors will drop in the spinal cord, and that's how they will cause the metastasis. Okay, these tumors are PTEN positive, PNET positive, right? Which is a primary neuroectodermal tumor, of course. These cells are the basophilic cells, not the eosinophilic. Okay, small round blue cells, basophilic blue. Then you have the ependymoma, which is a tumor of the all these ependymal cells surrounding the ventricles, and that's why they will block the ventricles, as you can see. If I go back, yeah. See this non-communicating hydrocephalus, you are seeing this mass, right? This is nothing but just a tumor of the ventricles, right? Ependymoma will be visible like that. Okay. Obstructing the ventricles, you will see the obstruction of ventricles clearly on the MRI of the patient, right? And that's how you know that the patient is having a ependymoma. As you can see, similarly, yeah, as you can see, you're having this kind of a tumor in the very center, obstructing your ventricles, right? I hope you guys can appreciate that.
Yes.
Yeah.
Okay. Similar thing could be seen, not on this tumor, but similar thing could be seen. It was the ventricles will be affected, right? Especially that is a main thing. The ventricles, if you see a mass within the ventricles and you're seeing the dilation of the ventricles, you will always think about the ependymoma. On what you will find on the biopsy of the patient. Okay. Just give me a second. This is ependymoma actually. Sorry about that, right? It will be affecting the ventricles. If you do this kind of a certain section of the patient, you can find this kind of a mass also. But please note that it is a kind of a hypodense mass, not a hyperdense just like that. Just like I showed you before, it was a hypodense mass obstructing the ventricles, right? On this kind of a section, you will see this mass here, right? That's the ependymoma, okay? And on the biopsy, what you will see are the paravascular pseudo-rosettes. Okay, not the Homer-Wright rosettes, but paravascular. As the name suggests, these are the arrangements of the cell around the blood vessels. Okay, you have these arrangements, the central, this kind of a circular-like appearances of the tumor masses of these tumor cells around the blood vessels. The paravascular pseudo-rosettes will be seen in the ependymoma. And why these paravascular pseudo-rosettes?
Because the ependymal cells are very closely linked to the vessels because they have to form.
Because they need to
CSF.
form the CSF, right? So they need the blood vessels to form the CSF. That's why the there's paravascular tumor. Then you have the cranopharyngioma, which is a tumor of the Rathke's pouch. And please note that the Rathke's pouch is actually derived from the ectoderm, and it will give rise to your what pituitary?
Anterior pituitary.
the anterior pituitary or the adenohypophysis, right? Now, you can have three components. See, in case of my pilocytic astrocytoma, or if I say in adults, what tumor can have both components, solid and cystic,
Glioblastoma.
and one more tumor,
Hemangioblastoma.
See, in these tumors, you have two components. One is a solid and one is a cystic, right? But in case of my cranopharyngioma, you have three components. One is a solid, second is a cystic, and third is a calcified. Okay, three components. You have a solid component that contains the actual tumor. You have a cystic component that contains some kind of a machine oil-like substance, liquefied oil-like substance. You have a calcified component. So whenever you encounter this kind of a tumor having three components, think about the craniopharyngioma. Okay, and yeah, so it would be a tumor of the Rathke's pouch involving the pituitary. Of course, you will have the bitemporal hemianopia. You will have the headache, right? And yeah, the crustal crystals will be found, which are in a motor oil-like. You will have the calcification. You have a solid component. Okay, and just like my adult, in case of my adult, I have this pituitary adenoma that will cause this headache and the bitemporal hemianopia. You have in children the cranopharyngioma, which is a tumor of Rathke's pouch, can cause the bitemporal hemianopia and the headache. So whenever you got this kind of a tumor involving the pituitary, think about the craniopharyngioma. Any doubt?
No, thank you.
And finally, you have the pinealoma, which is tumor of the pineal gland. It can cause the Parinot syndrome, in which you have the vertical gaze palsy, along with the obstructive hydrocephalus. Your eyes cannot raise upwards. Okay, you have this kind of a retraction type of nystagmus. Okay, and please note that this tumor can cause the HCG production, and that's why you call it a germ cell tumor of the brain. You have the germ cell tumors in the testis and the ovary, right? That can release the beta HCG.
Yes.
You have similar tumor in the pinealoma, okay, that can release the beta HCG also. Okay, and remember the Argyll-Robertson pupil?
Yeah, accommodation reflex is preserved.
But you won't get a pupillary reflex, right?
Yeah.
And where does you find this condition other than the pinealoma?
Syphilis.
Syphilis. So please note, only in two conditions you can find the Argyll-Robertson pupil. One is a syphilis and second is the pinealoma. Okay, so a patient with headache, vomiting, seizures, altered mental status, now having this vertical gaze palsy and the Argyll-Robertson pupil having a high level of HCG. Think about the pinealoma, a counterpart of the testicular seminomas, right? And that would be all about all the tumors. Any doubt?
No, thank you.
So again, just like my adult tumors, think about you need to know about this MRI, CT of the patients, right? You need to know about the biopsy. Okay, what you will find the gross findings. Symptoms will be similar for every tumor, same like the hydrocephalus, seizures, headache, nausea, vomiting, focal neurologic deficits, similar for any of the tumors. So symptoms won't help you identify the cause, but the CT, MRI, or the biopsy of the patient does. So you need to have a differentiating features. So we will take a short break again, and then we will finish the herniation syndromes. Okay.
I have a question from the previous page. You said that all these tumors in the children, they involve the cerebellum.
Yes.
But how does craniopharyngioma and pinealoma involve the cerebellum? Because they are not very close to the cerebellum.
Yeah, but they do not involve the cerebellum, of course. They have no link with the cerebellum, or the only two tumors which have no link with the cerebellum, we can say, right?
Okay, so they don't involve the cerebellum.
No.
Okay.
If they become very large enough,
sometimes
the pinealoma can cause the symptoms for the cerebellum also, but not the craniopharyngioma. You can have just the headache and the bitemporal hemianopia, nothing else.
Okay, yeah, got it. Thank you.
Exceptions are everywhere, of course.
Right. Yeah. Thank you.
Okay, so we will take a short break now.
Yes, thank you.
Because you have a very limited structure, because you have a very limited space in your brain for every structure to occupy. Okay, even if a slight increase in pressure happens or any decrease in the size of cranium happens, that will cause the herniation of the structures. Different type of herniations are there. Okay, you have the cingulate type of herniation, you have the central or transtentorial herniation, you have the uncal herniation, and you have the cerebellar tonsillar herniation. But let's first discuss the cingulate or the subphalangeal herniation that happens under the falx cerebri. And if you note the location, the anterior spinal artery run very close to it. Sorry, the anterior cerebral artery run very close to it, right?
Yeah.
Yes.
So because of any kind of a herniation when happens, it will cause a compression of the anterior spinal artery, and that can lead to the paralysis of the lower limb, sensory loss of the lower limb. If you look for the homunculus, right, the patient will have a contralateral lower extremity weakness. Please note, pupillary involvement is not there. Okay, consciousness is totally preserved. It's just you're having a this kind of a stroke involving the ASA because of the herniation, and that is the subfalcine herniation. Okay, that happens for the cingulate herniation, right? As you can see. Second, you have the central or the downward transtentorial herniation that happens like that. Okay, it happens because of the displacement, a downward displacement of your brainstem, and that can lead to the rupture of the paramedian basilar artery branches. Okay, and that can lead to the loss of sympathetic, parasympathetic innervations. Fixed pupil will be seen in the eye. Okay, your eye cannot move anywhere because all the midbrain structures are damaged, pons are damaged, right? Third nerve is gone, so you won't have any sympathetic system, sorry, you won't have any parasympathetic system to your eye. Okay, the sympathetic fibers are also get damaged, so you won't have any sympathetic supply to the eye. So a fixed pupil will be seen, and this condition is totally fatal. Okay, and this is the downward displacement of the brainstem known as the transtentorial herniation. Now comes the most important one, and that is the uncal transtentorial herniation. That happens because of the uncus, herniation of the uncus, and uncus is the most medial structure of your temporal lobe. Okay, now because of the herniation, the cranial nerve 3 lies very close to it, and because of this herniation, it compresses the cranial nerve 3. So you will have the cranial nerve 3 the palsy. Okay, and please note that the Edinger-Westphal nucleus is first affected and then the motor nucleus. You have a full-blown pupil with a downward and the outward movement of the eye. You cannot trace the eye upward, medially. Okay, extorsion of the eye will be kind of inhibited or defective, right? So this is the most common presenting complaint, the unilateral cranial nerve 3 compression. Okay, you will also have the contralateral hemiparesis. Okay, very important. And please note, initially what happens is, in a very early stage, okay, because of the ipsilateral cerebral compression, okay, you will have the contralateral hemiparesis. Okay, and please note, it is a cerebral peduncle compression. Okay, and the crossing over happens in the cerebral peduncles. If you look for the tracts, let us suppose this is my cerebral hemispheres. Okay, these are the peduncles, let's say. Okay, these are my cerebral peduncles. Okay, these are all my peripheral structures. Okay, this is my spinal cord. Okay, and let's draw a midline here. This is a midline. Okay, now you guys know, whatever sensory input coming to my brain, it will always cause a crossing over. That means if it is my right-sided structure, all the fibers will be running in the left side, right?
Yeah.
And these fibers will be running in the left side, and when they reach the cerebral peduncles, again the crossing over will happen in the cerebellar peduncles. And after this crossing over, the fibers which are running on the left side, they will again reach on the right side. And as a result, whenever a damage to my cerebellum occur, that will cause the ipsilateral symptoms, right?
Yes.
Now, because of the damage of these peduncles, as you can see, contralateral symptoms will be there.
Right.
Right. So because of this herniation, because this herniation initially involves all these peduncles, you will have a contralateral hemiparesis first. Okay. Now, as the herniation expands, okay, what you will have is the compression of the contralateral peduncle, and because of that, patient can have the ipsilateral hemiparesis. Initially, contralateral hemiparesis, and then the ipsilateral hemiparesis will be there, and that is known as the Carnahan phenomena. It will look like that the that the herniation is happening on the right side, but actually the herniation was happening on the left side. It first compresses the left-sided peduncle, so symptoms occur on the right side, then compresses the right peduncle, symptoms happen on the left side. Okay, this is the Carnahan's notch or the Carnahan's phenomena. Is that okay up to here?
For this phenomenon, do you have, I understand that early you have the ipsilateral cerebral compression, and that gives you contralateral hemiparesis. And then
Yes.
late, I have ipsilateral hemiparesis. In the late, do I have ipsi and contra or only ipsi?
Mostly you have the ipsilateral only, because as this herniation expand, see initially the if I take a zoom, see initially let's suppose the herniation was here, right? As this herniation expands, what's gonna happen? The herniation will be like that, right?
Yes.
So only unilateral symptoms will be present. But sometimes if the herniation is large enough, then both the ipsilateral as well as the contralateral symptoms will be there, right? So both can happen. Most commonly ipsilateral, most commonly unilateral symptoms. Sometimes bilateral symptoms can also happen.
Okay. Okay, thank you.
And so yeah, first of all, you will have the ipsilateral full-blown pupil. Okay, it cannot move down and outward movement. You will have a contralateral hemiparesis. In the lately, you can also have the comma. Okay, you will have the contralateral full-blown pupil. Okay, you will have an ipsilateral hemiparesis due to the contralateral compression against the Carnahan's notch, and that is the contralateral cerebellar peduncle. Okay, that's about my uncle herniation. And please note, it causes the hyporeflexia. Okay, very important, because of the spinal shock. Okay, spinal shock can happen because of the spinal cord compression. Patient can have the lower motor neuron palsy also. Okay, and yeah, and please note that uncle herniation is the most common type. Okay, all the disorders that we have studied previously, all these hemorrhage disorders can cause the uncle herniation. That's why in all the hemorrhage disorders, you can have the full-blown pupil with down and out movement. Okay. And then finally, you have already studied that the cerebellar tonsillar herniation, okay, which will be herniating into the foramen magnum. It can compress your spinal cord, right? It can cause the death directly. And you can have the Cheyne-Stokes respiration in case of the cerebellar tonsillar herniation. In case of uncle herniation. Okay, this is also a very important thing. Okay, with any herniation, actually, you can have it, not just with the uncle herniation. With any kind of a herniation, you can have this Cheyne-Stokes respiration. Okay, in which you sometimes have the signals for the respiration. Then, for a transient period of times, the signals for the respiration are inhibited. You will get a sudden waking from the sleep, gasping for the air, right?
Yeah.
We will say that later in the respiratory section about the Cheyne-Stokes respiration. I will tell you, with the heart failure or with any of the brain herniation, you can have this Cheyne-Stokes respiration. Okay, so note that for now. You can have the cardiopulmonary arrest because of the cerebral tonsillar herniation, so it is always very deadly. Okay, it compresses the medulla, can cause the death directly. So, any doubt on the herniations?
Could you please explain the cingulate herniation once again?
See, you have this cingulate gyrus here. Okay, that separates the two hemispheres. Okay, just near that, you're having the running of this anterior cerebral artery, right?
Yeah.
So whenever the herniation happens under this falx cerebri, okay, you're having the compression of the anterior cerebral artery. Okay,
All right.
and because of that, you can have, if you look for the homunculus, I told you that very medial structures are supplied by the anterior cerebral arteries, right? And the medial structures are corresponding to your lower limb and up to the hip level, right?
Yes.
So you will have a contralateral lower limb paralysis, as well as sensory loss, as well as the incontinence. Okay, these symptoms will be present in a cingulate or the subfalcine herniation. Any more doubt on these herniations?
No, thank you.
Then you have a difference between the upper motor neurons and the lower motor neuron signs. One is the weakness, will be present in both of the disorders. atrophy will only be there in the atrophy will only be present in the lower motor neuron damage, not in the upper motor neuron damage. Fasciculations will be present in the lower motor neuron damage. That means that twitching things, not in the upper motor neurons. Reflexes will be increased. That means you get the spasticity and the hyperreflexia. You can see an increase in the tone because of the upper motor neuron lesion, and you will have a decrease in the tone, decrease in the reflexes, decrease in the spasticity in case of lower motor neuron lesions. Babinski are always present whenever you get a frontal lobe damage. That means the upper motor neuron, because the primary the primary motor this cortex is present in the frontal lobe, right? So with the upper motor neuron lesion, you can have a Babinski sign also. Flaccid paralysis will be present in the lower motor neuron lesions, not in the upper motor neuron. Spasticity will be present in the upper motor neuron. Clasp knife reflex, spasticity will be present in the upper motor neuron. And does anyone know what nerve takes this reflex? So not the nerve, but the receptors that are responsible for this reflex.
Golgi tendon.
Yeah, the Golgi tendon reflexes. Okay, it was a Golgi tendons. Whenever the tension in your muscles increases, you will have the relaxation. In case of upper motor neuron, you have already very high tone, very high tension, and that causes the clasp knife reflex. Whenever you have to lift something, even a very little weight, you will have the relaxation, right? And one more thing you will get with the upper motor neuron lesion is the pronator drift. Always look for that, because in case of upper motor neuron lesion, you have more pronation than the supination. And so on the examination, okay, if you kind of if you stand the patient with their hands supinated, okay, and as soon as you leave the patient's hand, what you will see is the pronation of the hands of the affected hand, I must say. Okay, if the lesion is present on the left side, then the right side of the hand will become pronated if you left them supinated, right? And what does it mean by supination? Where is my palm facing?
Towards the anterior side.
Yeah, your palm will be on the upper side or the anterior side. So if you take the patient, if you keep stand the patient like that, okay, if you keep the patient like that and you ask them to face their palms upward, okay, what you will see on the affected side, if it's my right lesion or left lesion, on the contralateral side of my limb, I will have the pronator drift. Okay, I will have the downward face of this palms. That means the pronation. Okay, and that is specifically seen in the this upper motor neuron lesions. Is that okay?
Yes.
So look for that also. Okay, and yeah, that would be all about the lesions. And please also note that in case of my upper motor neuron lesions, the weakness is more pronounced in the lower extremity flexors and the upper extremity extensors. Okay, that means in the upper extremity you will get the flexion, in the lower extremity you will get the extension. And does anyone remember the name? What type of posture is it? When I get an upper limb flexion and the lower limb extension, what posture is it? The red nucleus, remember?
Decorticate.
Decorticate, exactly.
Decorticate.
It is a decorticate. Or is it decerebrate?
Decerebrate extension of lower limb.
Yeah, exactly. Okay. So for both the extension, decerebrate, decorticate means, no, I think we are confusing it. I think it was a decerebrate having the flexion of the upper limb. Let me confirm it. Sorry about that, I'm forgetting. Yeah, it was a decorticate, not decerebrate. Sorry about that. Okay, so decorticate, flexion of the upper limb, extension of the lower limb, and decerebrate, extension of both the upper limb as well as the lower limb, right?
Yeah.
So do remember that. It is highly confusing thing, I know. Okay, finally you have the AV malformations. And does anyone remember any disorder in which you have multiple AV malformations?
Paget's disease of the bone.
Not the Paget's disease. It is actually a kind of a complication, you can say. A disease in which you have a primary AV malformations. The disease which is because of these malformations.
Like
Heart failure.
In
Hereditary hemorrhage. Hereditary hemorrhage.
Exactly. Hereditary hemorrhagic
Hemorrhagic
telangiectasia, also known as the Osler-Weber-Randolph syndrome, right? In which you have a multiple AV malformations. You can have a these AV malformations in the lungs. And does anyone remember the feature, a specific feature for the lungs that I have in case of my Osler-Weber-Randolph syndrome?
Hemoptysis.
Okay, you will get the hemoptysis first, or a very specific thing which is not seen in other disorders.
Raised red lesion on
What thing?
Telangiectasia?
Oh, that would be on the skin, right? You can't say telangiectasia on the lungs. So, any other?
I don't. What question?
See, a symptom in the lung that is not present in any of other disorders. Like it is highly specific, you can say, for my Osler-Weber-Randolph syndrome, a lung symptom. No?
Do you get pulmonary hypertension because you don't transition from the artery?
You
to
can
the
get a pulmonary hypertension in a normal primary hypertension disorders also. So not very much specific, although you can get a hypertension, don't worry. You will get the osteodystrophy again of the limbs, like this clubbing vagara, right? This will be also present in other disorders. So not very specific again. Platypnea, remember? The opposite of orthopnea.
So easy breathing?
Yeah.
Can you explain that, please?
See, in case of orthopnea, you're having the shortness of breath whenever you lay down, right?
Yeah.
In orthopnea, you're having shortness of breath whenever you stand up or sit down. While you lay down, you will have a resolution of symptoms. But when you sit down or stand up, you will have the shortness of breath. And that is also platypnea. Okay. This condition can only be seen, I think, in case of myxoma, cardiac myxoma, first. And second, in the Osler-Weber-Randolph syndrome. Okay.
Okay.
So do remember that platypnea, that is the opposite of your orthopnea. Okay. So let's come back to again. So AV malformations can be seen in the Osler-Weber-Randolph syndrome. Please note they are mostly asymptomatic. Okay. And these are generally incidental finding on the CT or MRI of the patient. Sometimes because they are kind of a mass, okay, they can cause the seizures also, sometimes the FNDs, but not very much common. What common in them is, sometimes because they are the AV malformations, the blood vessels become very much dilated, very much leaky. So hemorrhage can happen, and the risk of hemorrhage is very much high because of these AV malformations. Okay, spontaneous hemorrhage. Seizures can occur, but mostly the conditions are asymptomatic. And step one will want you to know how to look for the AV malformations on the CT. And what you will see are the flow voids. Let me open it for you. I think I have this in my file. Just give me a second. So as you can see on this CT or MRI of the patient, you will see these kind of flow voids. Okay, when you do the MRI of the patient, these kind of flow voids will see representing the dilated blood vessels. Okay, and whenever you get this kind of a CT, this kind of a flow voids, like the empty spaces, you will immediately know that the patient is having a AV malformations. Okay, they will just give you a patient with a history of seizures. You perform the MRI, and they will give you this kind of a CT, and they will ask you what's happening to the patient, and you need to identify the AV malformations. All these are the blood, and these are the flow voids because of the increase in the flow of the blood from here. You will have the empty spaces on the CT. Is that okay?
Yeah.
If you do the angiography, what you will find are the worm of bag-like appearance. Okay, on the angiography of the patient, worm of bag-like appearance in case of my AV malformations. Okay, so look for the CT, look for the angiography also. Okay, so yeah, it would be the it happens whenever the artery directly anastomosis with my veins, and as a result, because of this high pressure flow, veins will become very much dilated, and that causes all these AV malformations. Seizures can happen. CT angiogram, Okay, it will reveal that cluster of the dilated vessels that will look like a worm of back like appearance. Okay, it could be shown with the hereditary hemorrhagic telangiectasias, also known as the Osler-Weber-Endo syndromes. Okay, other things can also be there like the mucocutaneous telangiectasias. We will have the history of bleeding, hemoptysis. Okay, in the GI tract you can have the melena, right? Platypnea you can have. Okay, so AV malformations in the lung, liver, brain, right? All these areas you can have. Patient will have a risk of the spontaneous hemorrhage. And whenever the spontaneous hemorrhage happen, does anyone know in what area of my brain I will have this hemorrhage?
In the cerebrum itself.
In the cerebrum itself. Are you sure?
Is it around the cortex? That's where it was on the picture.
Think more. We have discussed that previously when we're discussing all the type of hemorrhages.
between the dura and bone.
Now, subarachnoid hemorrhage,
No idea.
AV malformations, remember? Look on your first aid, you have mentioned that AV malformations can cause the subarachnoid hemorrhage, okay? So they will ask you this, subarachnoid hemorrhage can cause the, can be caused by the AV malformations. And that was the AV malformations we're talking about there, right? If you have a tumor, where can you have the hemorrhage?
At the site of the tumor, where they're getting the blood flow to make the tumor.
What kind of a hemorrhage I can say? Subarachnoid, epidural, subdural. Like in case of my parenchymal, yes, parenchymal hemorrhage. Okay, so they will give you a history of the patient having a tumor or having a AV malformation or having a hypertension, old age, something like that, and they will ask you what could be the complication of this condition. If the bleeding happens, then bleeding happens where? They will ask you whether it is a subarachnoid, whether it is an intraparenchymal, or something like that. Okay, so you do need to remember every example of every hemorrhage. Okay.
Okay.
How is this AV malformation different than the AV malformations we see in Paget disease?
Both are same. Both AV malformations are same. No difference. It's just the association is different, right? These AV malformations are associated with only the Osler-Weber-Endo syndrome. But in case of my Paget's disease, the AV malformation was happening because my cells desperately need the oxygen, right?
Yeah.
And in doing so, I was having the AV malformations in my bone. In case of my Osler-Weber-Endo syndrome, the primary disorder is of these AV malformations. Okay. In case of my Paget's disease, that was a complication. In case of my Osler-Weber-Endo syndrome, it is the primary disorder, right? There is a huge difference between them. But all these conditions are same. In both of them, you're having this high flow of the blood. This high output cardiac failure can happen in both of the conditions. Okay.
All right, thank you.
Okay. Now, any doubt on this page?
I have one question.
Do ask.
How is AV fistula different from AV malformation?
Same thing. No difference.
Okay, all right. Okay, thank you.
You can call it AV fistula. You can call it AV malformation, right? Both things are same.
Yeah, thank you.
Any other doubt?
No, thank you.
So remember about all these herniations, which herniation can cause the ACA compression, which herniation can cause a compression of cadence of 3, and then your Carnahan notch and other things, what herniation can cause chain stroke aspirations, right? Tonsillar herniation can cause a directly death because of the inhibition of medulla. Remember the signs of the motor neurons. Okay, the important ones are the Babinski, Glastonbury reflex, and the pronator drift. That will be seen in the upper motor neurons. In the upper motor neuron, you have the flexion of the upper limb and the extension of the lower limb because you have the weakness in the extensors of upper limb and the weakness of flexors of the lower limb. These are the, because all these things you already know, the weakness, atrophy, fasciculations, tone, all these things you already know. Okay, so the important ones become the Glastonbury reflexes, pronator drift, Babinski, and the this thing, right? The fact about the upper motor neuron, the lower motor neuron, right? If there's any doubt, please ask.
No, thank you.
So I think we should stop here for now, right?
Okay, yeah.
Okay.
I think we will finish this. Yeah, we finish this neuro, I think, in the next session or maybe the next after next only. 2 more classes, we'll finish the neurology completely, okay?
Okay.
All right, thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you so much. Thank you.
Thank you.